Programa sábado 17 de septiembre de 2024. Coordinador profesor Dr. Gils Weiss. Preservación del movimiento. 5, 6, 7, prueba de audio 1, 2, 3, 4, 5. Y dale para abajo, estoy muy separado. 5, 6, 7, 8, 9, 10, 11, 12. Dale menos. 1, 2, 3, 4, 5, 6, 7 menos. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 22, 23. Quítale ganancia. 1, 2, 3, 4, 5, 6, 7. Menos ganancia. 8, 9, 10, 11, 12, 13, 14, 15. Sí. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 22, 23. Prueba de micrófono Shure. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Estamos a 90 decibeles. 1, 2, 3, 4, 5, 6, 7. 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 18. Séptimo simposio, columna Guadalajara, prueba de micrófono 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Prueba de micrófono de podio 1, 2, 3, 4, 5, 6, 7. ¿Estás ahí?
Oye, Mari Carmen. Allá en Estados días. Pues queremos empezar.
No tengo audio. Ya. We are now going to start with Professor Gilles Dubois, who will discuss the motion preservation with intraspine, with biomechanical, histological, and clinical studies. Welcome, Professor Dubois. ¿Dónde está el internet? ¿Dónde está el internet en mi pantalla? Si alguien me puede apoyar.
So, nice.
Muy bien.
Dear colleagues, thanks a lot to the organizing committee to invite me for a talk on the motion preservation with intraspine. As you know, motion preservation, it's the dynamic stabilization. And the best definition was given by Jacques Sénégas from Bordeaux, which defines the principle of dynamic stabilization consists in both increasing the stiffness of the intervertebral segment and helping the mobility to stop the otherwise inexorable course of degenerative disease and possibly, in some cases, to foster the healing of the least severe lesion. So, the right place for dynamic stabilization is between the conservative treatment and before the fusion. We want to avoid it. So, what gives the dynamic stabilization? First of all, with the range of motion. If you study the effect of the implant on the kinematics of the human spine in three different situations, as intact, after artificial destabilization, and then after restabilization with a dynamic implant, or you can compare also with a rigid device. And so, as you can see in blue, the normal behavior of the intact spine, in green after destabilization, in red after restabilization with a dynamic device, and then you can compare with a rigid fixator. And as you can see, the value in terms of maximal flexion and maximal extension are very near between the normal spine and between the spine with a dynamic restabilization. So you restitute, in fact, the genuine stiffness. And so you have an impact. In the motion, you restore the normal segmental mobility. We did an example, a study on a young patient to know how she moved before the surgery in pink when she wants to flex. In fact, as you can see, she bends laterally, and 6 months after dynamic implantation, we restore a normal motion in the sagittal plane in yellow. The same on this happy view. Before surgery, you have a cloud of points which demonstrates the instability, and after restabilization, you re-engage a normal motion. And as you can see, the displacement after stabilization is more important than before the surgery, probably because pain disappears. And so you have an impact with dynamic stabilization on the disc. And as you can see on the right, 6 years after a dynamic stabilization, you have a marked improvement of the situation with rehydratation on the disc, disappearance of the small bulging existing before, and there is no consequences above and under 6 years after dynamic stabilization. So you have also an impact on the unplay. And so Jacques Sénégas said possibly in some cases foster the healing of the least severe lesion, but in fact also in eldest lesion, like in this modic one on left. As you can see, 5 months after stabilization, you re-engage a better function and a better nutrition of the disc, and the modic sign disappear. So what happened in the disc, and especially in the atmosphere of cellular? Nicolas Pecchia from Ancona did a very interesting job, and he demonstrates that in degenerative disc is made of fibrous cartilaginous tissue, which is rich in microvessels, cells, cytokines, and growth factors, and poor in proteoglycans, in water, and type 2 collagen. After stabilization with a dynamic device, we demonstrate after biopsy that the neutralized disc is made of fibrous cartilaginous tissue, but rich in proteoglycans, water, and type 2 collagen, and poor in cells, cytokines, growth factors, and microvessels. And so the neutralized disc seems to be similar to a normal disc. Another study confirmed this increase in terms of sulfated glycosaminoglycans with gadolinium-enhanced imaging. You quantify the gags in the disc. More simple, as you can see on left, at the level 4-5, you have some yellow and brown coloration, and in fact, more gags you have in the disc, and more blue is the image. And you can control 6 months after the stabilization that you have an increase in terms of blue coloration at the level of the stabilization. And if you did a new approach in 2 years, at 2 years follow-up, you can see that you have a real healing process with a lot of gags in the disc at the level which was stabilized, but also above and under. And so you have a regional impact of the dynamic stabilization in terms of recuperation. So what happened in terms of intradiscal pressure? As you know, probably in the posterior part of the disc, when you stabilize, you suppress the variation in terms of intradiscal pressure between flexion and extension. But you maintain this phenomenon of variation in terms of intradiscal pressure in the anterior part, and so you re-engage the pump effect. And it's the reason why you can induce a better physiology and a healing process could take place. So In terms of ASD, as you know probably on left, above a rigid construct, you increase intradiscal pressure around 20%. And on right, above the fusion, you have a dynamic device, and you increase at the level above only on 10%. So it's the reason why you can protect the superior level. Two-level hybrid construct, the increase of intradiscal pressure at the upper adjacent segment to a dynamic instrumentation is less than in rigid construct. And the raise of intradiscal pressure at the adjacent segment to a rigid instrumented segment can be neutralized with this is augmented with a dynamic stabilization device. And so, definitively, for us, there is a large field for dynamic stabilization before the fusion in terms of the treatment of DDD. And for us, today, the best solution, the less invasive solution, could be the interlaminar solution, whose name is intraspine. There is three different parts. First, the nose. The nose is uncompressible and is placed between the lamina. The posterior part is the tunnel. It's a soft posterior shock absorber, enables the full motion preservation. And around, you have the wings, which prevent all migration to the canal or backside. And you have a polyethylene terephthalate sheet around to enable tissue adhesion, to facilitate the implant stability, and the nose is protected with a silicone film, which is an anti-adhesion sheeting to prevent adhesion with the neurological structures. The right place is the interlaminar seating. It's very important. The anterior part is designed to sit between the lamina, close to the instantaneous axis of rotation. And so, this unique position has been shown to first reduce posterior loading on the disc, second, maintain the roam, third, restore the posterior tension band, fourth, restore facet congruence, fifth, restore foraminal 8, and maintain the lordosis, which is very important, as you know. Simultaneously, the approach is very important. As you can see on left, you have an open approach with some trouble in the muscles, and in the same view on right, it was a Wilson approach, and you maintain the muscle. And on right, you have a Wilson bilateral approach, and you can confirm that the muscles are well present, and also the supraspinous ligament is intact. So it's very important when it's feasible to use less invasive surgery. And we know that the interlaminar position permits the normal motion, and you can control this fact with the opening or the closure of the tunnel. In extension, the tunnel is closed. You can see it in neutral position and is largely open in flexion. So the compression of the tunnel is made to absorb excessive load in extension. And in fact, the small impact in terms of posture is very important. This is an example of an old woman of 80 years old. We stabilize at the level of 3-4, and as you can see, we have a huge change in terms of posture and in terms of sagittal balance. So, however, fusion remains a good option for many indications. But you know also that when it's not very well performed, we have a lot of disappointment, has facet hypertrophy, sometimes fractures, canal stenosis, disc degeneration, spondy, scoliosis. It's the reason why above a fusion, we can protect during sometimes the adjacent level with a dynamic device as intraspine. So, what to remind about intraspine? First of all, we don't lose the correction as you can control on this dynamic X-ray. Second, you reopen the foramen area, and we have the excellent job did by VII in Korea, which demonstrates by measure that it's a reality. You really reopen the foramen. You preserve the lumbar lordosis. You don't induce kyphosis. This is an example of a fusion at the level 5-1, and 2 levels above were stabilized in the same time, and the control after 7 years demonstrates that we have no influence at the level above the fusion and the stabilization. So you stop or reverse the DDD cascade, and this is another example with huge prolapse, which was released, and a stabilization was did, and you have the control 7 years later on the right with nothing around the level which was stabilized. Another example with this recurrence of disc herniation, which is removed, and the level is stabilized, and we can stop the DDD at this level. So we will see some personal case to demonstrate the field of the indication. A female of 66 years old with a bilateral lumbocurosciatalgia in standing position, mainly on the right side, and the pain disappears in a decubitus position. So it's a real mechanic pain, and RMI shows a stenosis with a discrete slippage of L4 and a real stenosis, which was liberated and stabilized after recalibration with an intraspine who was 14 millimeters high. And so, in fact, we have a good impact in terms of balance. The lordosis come from, she wins 7 degrees, and we have a more posterior position in terms of SVR. Other example, a 2-level disease with real stenosis at the level 3, 4, and 4, 5, decompensated by a disc herniation on left side with bilateral pain, sciatica on left, failure of the medical treatment, and so stabilization after recalibration at 2 levels, and results stable during time. Another example with this female, which was 49 years old, and she has left crural and sciatic lumboradiculalgia with steppage of the levator muscles due to 3-4 listhesis, increasing pain and limitation of the perimeters. She stopped her work for 2 years, so we decide to stabilize this level 3-4, and we obtain a good suite in terms of pain, of lower back pain, and the neurological deficit was in rehabilitation therapy. So the ultima to demonstrate that dynamic stabilization could be also addressed to the eldest patient, and this is an example of a woman of 81 years old with both sides crural and sciatica. She was under morphine, and she had a previous surgery at the level L5-S1, and now she has stenosis at the level L4-L5, which is structural, a little bit bony, but also a soft stenosis with a discrete antelisthesis. And as you can see, the PIRA view on right, when you distract the level, you must maintain a local lordosis, and you be sure to have the right size of the device when the posterior wall of the vertebra are aligned, and so you have the right size to implant the device between the lamina. This is the anatomic results with a clear opening of the foramen with an intraspine of only size 10 millimeters. And so I am not alone to be convinced to use this device in the eldest patient. The last publication was a case report coming from Korea, and it was concerning two patients described in this report, where 87 and 81 years old women with real documented fragility fractures, and both patients has a severe osteopenia and real compression. So after a discussion with the patients, they decide to undergo non-fusion spine surgery. After the surgery was performed, the patient back pain and lower extremity numbness disappear within 3 months. Thus, the clinical outcomes were successful. Just an image to few words concerning another device of dynamic stabilization we can use, whose name is VII. This is an example of an obese female which has a previous surgery, two-level fusion 2 years before, and she come back with a severe lower back pain without radicular pain, with a back VAS to 9. And so, in fact, she has no radicular compression, she has a wide canal, an hydroarthrosial articular process inflammatory, and an interspinous effusion. This is the dynamic X-ray with a discrete instability at the level 3-4, discrete retro, which increase in retrolisthesis in extension. And so we decide just to stabilize this level. As you can see on the right, with this device, we change the rods and we implant the bumper of Bedin, and so we obtain quite a total disappearance of the pain. This is the post-op control from the front. So I thank you for your attention. Thank you, sir.
Thank you. Muy buenos días. Agradecemos al profesor Dubais por su excelente presentación Y sobre estos
Professor for his excellent presentation and the biomechanicals of
Good morning, everybody. I hope you all had a nice evening last night. I discovered that tequila is actually quite a strong drink, isn't it? And if looking around the room, I think there's a few casualties this morning. But I can see people filtering. But it was a fun evening, good fun. But here we are. So well done if you've made it. I'm not going to make this talk too heavy. This is really an opportunity for me to show you my rationale for dynamic stabilization and how I incorporate that into my practice. And I just really want to share what I've learned and why I do what I do and how I think about it. So as some of you know already, if you heard my previous talk, I'm a consultant spinal surgeon, and I'm based in London. Just to remind you where the UK exists, I'm 6,000 miles away from home and still slightly jet-lagged, but having a good time in Mexico. And as I told you the other day, I'm dual qualified. This is important. I'm an engineer and a surgeon, and I have a doctorate actually in motion-preserving technologies in the spine. So I know lots about dynamic stabilization. So if I think about my practice, is it perfect? If you think about your practices, are they as good as they can be? And these are just a few thoughts in terms of where I think there is room for improvement. So discectomy, this is a very common thing that we do all the time, but low back pain after discectomy is common, up to a quarter of patients. Recurrence rate after disc herniation. I quote patients 7% risk of this. And it's a real nuisance, isn't it, when you've done a good operation and then they have a recurrent disc herniation. And then adjacent segment degeneration. 16% at 5 years, 1/3 of patients at 10 years. So it's inevitable with fusion. And Bertolotti syndrome, I'm sure most of you know what that is, but of course that's transitional lumbosacral anatomy. So what we're referring to there is sacralization of L5, and this effectively stiffens up the lower part of our back. It's like going through life with a fusion. And actually that's bad, because what we see is that disc degeneration is 9 times more common adjacent to that level. And if you're going to get stenosis, that's the level you're going to get it. And we see that very commonly in practice. So what about fusion? I mean, I do lots and lots of fusions. Well, what do we think about it? Well, it's a well-practiced option, isn't it? And if I show you these cases here, on the left, we have a trauma. We have a bony chance fracture, which we'd all recognize in the room is an unstable injury. And I think most of us would certainly consider fusing that type of injury. And then, of course, we've got the more chronic situation on the right, which is our degenerative scoliosis. And, of course, we all know that's a nightmare to treat, and that's going to take a huge amount of time and effort. It's going to be hard for the patient, probably even harder for the surgeon, and trying to manage those things, and whether you choose to take those kind of problems on is a decision you have to make and accept the complications that go with it. So what about listhesis? When I started my practice as a consultant and I trained different parts of the world, including New Zealand, listhesis basically equaled fusion. Any listhesis, fusion. And I think we'd probably agree, faced with an isthmic spondylolisthesis, it probably still is. But what about degenerative spondylolisthesis? Maybe I'll ask for a show of hands here. Who would always fuse an isthmic spondylolisthesis when operating? Okay, so lots of hands going up. What about a degenerative spondylolisthesis? Who put your hand up if you'd always tend to fuse that scenario? So we've got a few, but I think that's a change. And I think if we look back 10 years, I think we'd see a lot more hands going up in the room. And I think there's much more reluctance now to fuse degenerative spondylolisthesis and perhaps to do something a little bit less. So this has been a big change for me in my practice. Most patients, of course, that we see in clinic day in, day out, don't have deformity. They don't have a traumatic injury, they don't have deformity. So I don't really want to do a fusion because it's a long operation, it's an expensive operation, it's technical, it's risky. Maybe it relies on the spine fusing, which doesn't always happen. And mechanically, it's bad for the spine. The spine doesn't like to be fused. Not a good thing to do. It might be good for the level you're treating, but the rest of the spine does not like it. And it's irreversible. That's the other big thing. There's no way back. Once you commit to fusion, there is no way back. So the other thing I see in my clinic is that it's just not the right patient. They're either too young or too old. And does this very nice, harmless-looking 85-year-old English lady, does she really want a fusion? I don't think so. So for me, when we're thinking about dynamic stabilization, we're thinking about that gap between conservative treatment and fusion. And I think it's a very big gap, and we have to think very carefully how we can evolve our practices to do better. So if we think about mechanical back pain, and I'm going to recap a little on what I said the other day because not everybody was here and a lot of people asked me questions. But if we think about mechanical back pain, there are two mechanisms. We see abnormal loading and we see abnormal patterns of movement, which we refer to as microinstability. And we think it's microinstability that leads to triggers these episodes of back pain, which we're very familiar. I told you the other day that loading across the motion segment, 80% goes through the anterior column, 20% through the posterior column and the facets. And I told you that disc degeneration leads to more force going through the posterior elements, which leads to facet joint degeneration. I talked about how the proportion of the load that goes through the disc changes with three factors: posture, sagittal profile, and age through disc degeneration. And we talked about that. And I gave you a model for spinal stability, and I quoted this one for Punjabi. And we talked about three subsystems: passive, active, and neural. And just to remind you, the passive subsystem is all the bits that don't contract. It's the ligaments, it's the joints, it's the discs. Whereas our active subsystem, or so-called the core, is our back muscles and our tummy muscles, or abdominal muscles, which is what we work on with rehabilitation and physiotherapy. And I showed you this graph, and I'm showing you this again, so you've had time to think about it, and now you can look at it again, so this will stick in your mind. So remember, this is a force displacement graph. And what I'm showing you here is in that neutral zone, a small force leads to quite a large displacement. And this allows us to move. This allows free movement. And this is our muscles which are controlling that. And then we hit an inflection point where the spine then starts to stiffen. And that's our passive subsystem. And as we get older, things are happening to that passive subsystem. Our discs are degenerating, is the big one. And so rather than our spine stiffening, we see an increase in that neutral zone. So our muscles will try to compensate, and we send the patients to the physiotherapists to have stronger muscles. But instability occurs when that neutral zone increases beyond the physiological range of the spine. So this is our gap. This is what we're looking at, the gap between conservative treatment and fusion. And dynamic stabilization is contributing to that passive subsystem, which is failing as we get older. Perhaps you're interested in disc biology, and I'm not going to labor this. Gilles Dubois has already mentioned this scenario, but essentially if we improve the biomechanics of the disc, we see positive changes in the disc. So the cellular environment changes. So mechanics and biology, or histology, are linked. And this is, of course, is very interesting, and this is the work of Senegas back in the 1980s, but there's lots of other papers that look at this. And this is the tantalizing prospect of disc healing. So if I'm thinking about a dynamic implant, what am I looking for? So remember, our center of rotation sits in the posterior third of our disc. So if we're using some implant, what are we looking for? We need to restore a normal range of movement. But not just a normal range, but normal patterns of movement. And we want our implant to load share. We don't want it suddenly to catch or kick in at some point during movement. And most importantly, unlike fusion, we don't want it to have an impact on the adjacent levels. So this is what we're looking for. So commercially, if you looked at this as a company, you'd say there's lots and lots of opportunity to produce implants that might be helpful here. And of course, the market was flooded with interspinous devices in the last 20 years. There's tens or probably hundreds of devices. And these were, I would say, very much rushed onto the market. Lots of surgeons accepted them without really understanding how they worked. They were used for a lot of wide indications. Evidence was lacking. Papers were poorly controlled and studied. And it really gave, I would say, interspinous devices a bad name. And I should say, I don't use interspinous devices. So if we look at a classification for posterior implants here, we're really dividing into non-pedicle-based systems and pedicle-based systems. And non-pedicle, of course, tend to be easier because you're not putting screws into someone's back with the risk that entails. And of the non-pedicle, you've got this very large group, the interspinous devices, which I don't particularly like, and I'm sure many of you would probably agree with me on that. But then we have an interlaminar device, and the only one actually that exists in the market at the moment is intraspine, which we've just heard about. But it does stand alone because of its positioning. And then, of course, the pedicle-based systems are things like dynesis, and there are others. So let's think about the ideal implant. So if we were designing an implant or thinking about it. So, of course, there's our center of rotation in the disc space. So, of course, this is disc replacement. And some of you in the room will probably do lumbar disc replacements. But it's an anterior approach. Do you want to be doing anterior approaches all the time? If you do enough, you're going to run into vascular complications. And it's a big operation. And also, it's actually very hard balancing disc replacements, I think, in the lumbar spine. And a significant proportion of patients are left with facet pain, and then you're in a stuck situation, because how do you undo that? And essentially then you're looking at a fusion, so it's irreversible. So what about putting something at the back of the spine here? Well, of course, this is our interspinous devices. And of course, this is a long way back from our center of rotation. And I told you in the lecture before that if we look at spinal movement, that we see rocking about that center of axis. So it's like a seesaw type of motion. So if we put an implant right at the back of the spine and constrain the spine, then essentially we are creating a hinge across the segment. So it totally changes the loading and forces. So this is our interlaminar position, and you can see it's quite smart. It's putting our center now closer to our instant axis of rotation. And because it's sitting between the facet joints, it has the ability to offload the facet joints. And we can restore or leave our tension band posteriorly, so we still see those rocking movements, which are important. So that's just really showing you the difference between the positioning of an interspinous device, which we don't really like mechanically, and an interlaminar device, which is sort of sitting between the facet joints and closer to that center of rotation. I like anything biomechanics, and just to point out to you, this was tested. We can control things in the lab, and we can measure things, and that's important. So Intraspine was tested at Ensemble in Paris, which is a very famous institute, and they looked at range of motion, intradiscal pressure, and motion. And just to summarize the study, what was demonstrated was that Intraspine has the ability to support the disc in flexion, and that's essential that you have an intact tension band at the back, so either the patient's own or you use the artificial ligament. But also it has the ability to load share with the facet joints in extension without being an extension blocker. So if we think about our indications for operating on patients, I've sort of split these really into back pain and stenosis. I mean, actually, I don't really consider myself a back pain surgeon. Most of the time when I'm operating for stenosis, I'm operating for sciatica, I'm operating for leg symptoms. I don't chase back pain. But what I want to do is stenosis surgery better. I don't want to make people's sciatica better, but leave them with back pain. So this, for me, is how Intraspine is, how dynamic stabilization is useful. But of course, there will be people in the room that do chase back pain. And of course, you might consider using it for facet, arthropathy, disc degeneration, topping off a fusion, or kissing spine disease. So I'm going to give you a few just simple examples, really, of when I might consider using dynamic stabilization. And these are the sort of patients that we see day in, day out in our clinics. So this is a young female. So straight away, I'm telling you, females are more likely to have back pain. Lots of evidence to suggest that. So she's young, she's female. She's got back pain and sciatica. She's got a large disc herniation at L5-S1. So this is the sort of patient that you're going to do your discectomy on. She's going to be pleased that her sciatica is better, but she has a significant risk of having back pain. And so for me, this is the type of example where I might consider using some form of dynamic stabilization to help that L5-S1 segment. And there's an example there of where we might use an implant at L5-S1. Again, a young patient where we don't want to do too much, and we certainly really don't want to be getting into fusion. So this is a 56-year-old male, and they've got a large L3-4 disc herniation. And the eagle-eyed people in the audience should have noticed that, of course, this is someone who has transitional anatomy with a rudimentary disc. And this should immediately be saying this is a stiff spine. So those levels, those bottom motion segments are working harder. So we're going to see premature degeneration, increased risk of back pain. So this is the sort of case where I would be doing a decompression or microdiscectomy, but also combining that with dynamic stabilization to provide some mechanical support to those to the segment which is working hard. So this is an older patient, a 65-year-old with severe central stenosis. So trying to do a decompression here from one side, a unilateral approach is going to be difficult, hard. So for me, this is a case where I would sacrifice the midline because I don't want to struggle with access. And actually, we've looked at studies where we've done this. If you sacrifice the midline, you have much better attack angle to the facet joints. So you can do a much more preserving facet joint decompression. And so this is the sort of case where we would sacrifice the midline, but then I would reconstitute that by using our interlaminar cushion and then using a ligament as well. So we're basically putting those posterior constraints back into the spine. So here's another one. We're getting older now. This is our older lady that I showed you before, 82. She's got right sciatic symptoms. So she's got a relatively stable spondylolisthesis, degenerative. So I don't want to do a big operation on her. I don't want to do a fusion. So again, this is someone where you could do really a minimally invasive type of decompression to make her sciatica better. But I want to give her some stability. Not too much stability, just enough. So this is, for me, is when the introduction of an intraspine does exactly that. Here's another one, 80 years old, female, sciatica, back pain. She's osteoporotic, so that's putting us off doing anything too major. And she's got a facet cyst. Again, when I started my practice, facet cysts equaled fusion. But I rarely fuse now for facet cysts, unless there's some significant deformity. So for me, this is a decompression to make the sciatica better, but I am concerned that there is a degree of instability at that level. So for me, this would be dynamic stabilization. So this is an interesting one. This is a 48-year-old male with low back pain. And this is why I guess I don't chase back pain. So if I said to you, where do we think this man's back pain is coming from? It's difficult. He's got some disc degeneration. It's going to be very hard to know where this back pain is from. But this is absolutely awful for this patient. And his life is destroyed. And, the surgeon has said, there's nothing I can do. I don't operate for back pain. And so he's gone through functional restoration programs. He's doing physiotherapy. Everything you can think of. He's in pain management. So roll forward 6 years, and nobody's wanted to scan this chap. So this is why you have to always keep your eyes open. So 6 years later, that's what his spine looks like now. So it just shows how, the spine can change very quickly. And we always have to be mindful that when we scan patients, it's a snapshot in time. And sometimes we see this is a total failure of that L4-5 segment. And of course, we would look at that and we would probably treat that, whereas we wouldn't have treated that 48-year-old male, or we would have struggled to. So here's another one. This is a 31-year-old female. Again, back pain, 2-level disc degeneration. Not somebody we want to fuse. But she went on to have dynamic stabilization. This is not my case, but you can see what was done here. So she had a 2-level dynamic stabilization. And 4 to 5 years later, if you look at her Oswestry scores, fast back, very good, back to normal life, working, paying taxes, very happy. So this is the sort of patient you might consider intervening, or are you going to say there's nothing that we can do? Topping off a fusion. Well, adjacent segment degeneration is radiologically inevitable after fusion. And for 30% of people, it's symptomatic at 10 years. So when we fuse people's backs, we have to tell them, 5 to 10 years' time, there is a risk that you will be back with more problems. So again, this is the type of case where I don't want to just keep throwing more metalwork at the spine, and I might consider using dynamic stabilization. Here's another example, 2-level fusion, L4 to S1. 10 years later, adjacent segment problems at L3-4. I don't want to start chasing this up the spine anymore. So for me, I can do something smaller. And this is, again, could be a case for dynamic stabilization. Kissing spine disease, Bastrup's disease, you might see this sometimes. This is a good one to treat because it's generally very successful treatment for back pain. You can see those enlarged spinous processes. We talked about how they enlarge with age. And again, this is an example where you might consider using some form of cushion. Foraminal stenosis is a difficult one. We have to consider this very carefully. There's different types of foraminal stenosis. So remember, this type of stenosis is when we see a retrolisthesis is caused by some failure of the disc, unlike antrolisthesis, which is caused by failure of the facet joints. So the loosening of the disc causes the segment to slide backwards, and this is the effect that we're seeing in the neuroforamen. So the type of patient we're looking for here would be someone who has a dynamic situation, so they have leg pain when they stand, but they're better when they sit. So again, I don't want to do a fusion on this. They want to treat the spine gently, and this is a good case where we might consider using an intraspine, which is going to sort of tension the disc and stop that sliding back into a retrolisthesis. So just to summarize my experience, I've done more than 300 cases of dynamic stabilization with intraspine. I would say it's a very easy thing to learn. It probably adds 5 to 10 minutes of operating time to a case. So most of the time I'm doing this following some form of decompression or microdiscectomy. So it adds just 5 minutes to the case at the end. The approach remains absolutely minimal. I don't need to make a bigger hole in the patient's back, which is good. And in my hands, certainly all patients that I operate on actually go home on the same day. So you can do this as day case spinal surgery. I'm not talking about that today, but actually one of the things we specialize in where I work in London is day case spinal surgery. We do multi-level fusions, and we send patients home on the same day. Everybody goes home on the same day. So I might do a talk on that at some stage, but it's amazing what you can achieve. It's been a safe implant in my hands. I've had 2 complications in those 300 cases. I've had 1 moving, and I've had 1 deep infection. So just some outcomes. 3 months, oswestry 48 to 18, VASPAC 4-point improvement, and then of course predictably, because I'm operating for sciatica, VAS leg is better. So just to summarize, if I'm considering dynamic stabilization, we're thinking about that gap. And so for me, it bridges that gap between conservative treatment and fusion. It gives me another option in my practice. And I'm doing that because I think there is room for improvement. We've talked about a biomechanical rationale when considering using implants. And I've told you how, of all those dynamic implants, posterior implants, personally, I like intraspine because of its positioning. That interlaminar positioning makes it different from interspinous devices in terms of how it behaves. It's non-metallic, so it's much, much less likely to loosen, and it's versatile. We can use it for quite broad indications. We have to use it selectively, but also, very importantly, it's reversible. So I'm not burning bridges if I do this. So I find it easy to use. I can still do that with a minimal approach. So in my practice, I found this conveys additional benefits without harm. Primum non nocere. Thank you very much.
Well, we invite Dr. Dubois, Gilles Dubois, to discuss different stages. El doctor Dubois nos hablará de diferentes etapas en la enfermedad discal degenerativa y su tratamiento.
Okay. Thanks again to the organizing committee for this kind invitation to speak around the concept of dynamic stabilization. We try to explain why during different stages of instability during degenerative disease, we can use a dynamic stabilization. And we use it after a long conservative treatment and before, when we are at the end of the DDD, before the total disappearance of the disc, so which is the real place for fusion, because definitive procedure should be done for a definitive lesion. So, as you know, during the natural degenerative history, there is a long time between the total disappearance of the disc and from failure of the disc to failure of the paraspinal muscles to arthritis of the facet, subsiding into the subsiding of the upper vertebra into the lower one, and finally stenosis or fused deformation, there is a large place which dynamic stabilization give spatial consequences. So we have a lot of tools to see the step of degenerative disease. And first of all, the dynamic X-rays can show small disstability, especially in hypomobile discopathy, and more affecting in the segments with normal discate where shifting of the vertebra occurs, spondy or retrolithesys. And this unstable phase also causes secondary compression phenomenon like articular cyst on left or due to dynamical stenosis on right. And so we have a lot of tools as classification of Fearman, for example, or the modic description to describe unplate inflammation and then fatty degeneration and then fibrosis. The classification of Hadar concerning the parapinal muscles and their fatty degeneration, and the pelvic parameters, the works of Yuval Beaupère with the pelvic incidence, which is very important. And so with this incidence, Roussouly can define 4 different profiles. But the most important point is the lumbar lordosis, which is in direct consequence of the incident. So, in practice, this is an example of a chronic lower back pain for 10 years on long sitting or walking. The VAS pain is around 8. What can you propose? The treatment options are very large. First, conservative with exercise, epidural blocks, neurolysis or facet rhizotomy, endoscopy for aminotomy with annuloplasty, and why not fusion surgery. In this case of the stage 1, 2, and 3 of Spearman, with a preserved disc and a predominant hyperintensity zone, we prefer laser annuloplasty and epidural adhesiolysis. The classic symptoms of the discogenic lower back pain is a sitting intolerance, extension cut, frequent button attack after physical loading, pain attack during position change, and difficulty to maintain same lumbar curvature. And so, when you detect in the bulging radial cracks, as you can see, you can perform a percutaneous endoscopy lumbar annuloplasty. You can see the result on the right with the disappearance of the hyperintensity zone in the posterior part of the annulus. And with the Fearman 5, probably we can, with this severe disabling back pain and a severe radiating pain, we can discuss 360 fusion, or if you have not important articular arthrosis, a TDR. In fact, during this long period where the Fearman is 3, 4, or 5 sometimes, with a decreased disc age, with dynamic foraminal stenosis, with facet syndrome, we thought that stabilization with intraspine could be enough to treat the patient. Spinal stenosis with central stenosis, lateral recess stenosis, and you can see the different types of compression in the foramen, or hard stenosis, thickening of the bony elements of the canal, lamina, and facet, calcification of soft component, ligamentum flavum and disc. As you can see here, a soft stenosis, and thanks to our friend Wolfgang Rauschning for this beautiful image. And if you have a spondy with an instability, you need so to stabilize. Today, we have the open upright RMI And you can see the variation in terms of area in the canal between flexion and extension. And so you can appreciate what is the most important part of the compression, bony or soft. And with a segmental buckling of tackle stack, disc bulge, and ligamentum flavum infolding in extension, once again thanks to Wolfgang for this beautifully made, which permits to understand what is a dynamic foraminal stenosis. On right, you see the impingement of the nerve root aggressed by the articular process. So during this long phase of compression with instability, when the disc is reduced, the foraminal ligament relax and thickening, encroachment of the dorsal root ganglion by the superior facet, with symptoms are back pain increased by standing, walking, and extension. In fact, during this long period, the key words stay instability and any type of stenosis. You have to remove bony or soft stenosis and to stabilize with intraspine. And what does intraspine make? It preserves the motion. And the motion preservation is the real philosophy, like minimally invasive surgery or endoscopic surgery. And the real, very important difference is the place where you must implant the dynamic device, which is an interlaminar device. And you have the two authors of this device with Guizardi in the center and with Petrini on the left side. One is orthopedic surgeon, Petrini, and the other is a neurosurgeon, well known around the world. So what is the effect of interlaminar spacer? You increase the disc space, and you have to be very careful to maintain a local lordosis. So you know the device with three portions. First, the nose, which is placed interlaminar situation, the posterior tunnel, which is a shock absorber, and the wings, which permit all motion without mobilization. And if you want to restore the posterior tension band, you can use the ligament posteriorly of the device. And so you can obtain a real stabilization. And this unique interlaminar position, closer to the instantaneous axis of rotation, allows to maintain the full range of motion and respect the sagittal balance. So, what are the goals? First, save the Rome. And we save the Rome in flexion and extension. Intraspine does not limit extension and control the flexion. A lot of publication was done on this topic, and it's illustrated by these dynamic X-rays after implantation. And so, second goals, you help the disc, like a posterior disc. You can see here, 7 years later, after a stabilization, that you have no consequences above, and the level which were stabilized are better in terms of positioning, hydration, and bony situation. So another goal is to increase the foraminal height. We know that the foraminal height is reduced for soft stenosis, dynamic stenosis, and when we have a reduction of the disc height. So the indication are the chronic low back pain with black disc and facet syndrome, soft and or dynamic and foraminal stenosis, all type of stenosis with instability. After operation for big herniation in young patients, so as to prevent the collapse and the collapse of the disc and the subsequent chronic low back pain. The insufficiency of the supraspinal fibrous complex. After operation for synovial cyst, during kissing spine, and especially in the elder patient. So we have a paper coming from Bai once again. He demonstrates and analyzes a series concerning the back pain, chronic back pain. He used it during 3, 4, and 5 steps of Spearman for 1 or 2 level degenerated disc, and with or without high hyperdensity zone in the annulus, with facet syndrome and or with retrolisthesis. When there is 1 or 2 level degenerative disc, Spearman from 3 to 5, with or without hyper zone, intensity, with facet syndrome and retrolisthesis. This is the population, around 30 patients. You see typical implantation in interlaminar situation with a retention of the posterior element of the disc, the operation time, the clinical outcomes concerning the back pain and the leg pain, the functional outcomes concerning the ODI, which decrease, the radiological outcome concerning the disc height, which is discretely elevated, and the lordosis is always maintained. Segmental lordosis and also regional lordosis. You can measure also the foraminal area, and you constate always an increasing of the area in the foramen. So it's a very long period of DDD in which we can just stabilize dynamically. At the end of the normal history, when the disc has disappeared, the disc collapse leaves sometimes a painful mobility. In this case, dynamic X-rays is often the best example. And if you have a local kyphosis, like in this example at the level 4-5, you must reduce and fuse. And you have to fuse, but you have to perform a good fusion. And you can help your decision with some classification. For example, this one was published by Professor Gilles, and he defined, in fact, 5 types: type 1AB, type 2AB, and type 3. Type 1A and type 2A are good indication for dynamic stabilization. TIP 1B and 2B are good indication for fusion, and especially the TIP 3 with a global sagittal disequilibrium with an SVR more than 40 millimeters. It's surely a deformity surgery, and it's not our topic today, but we chose just an example to confirm the real interest of the sagittal balance concerning the analysis of the pelvic parameters. This is an example of a fusion because she had an important kyphosis, local kyphosis. So a fusion was done with an hyper too much lordosis, and in fact we don't respect the normal angles, and quickly after the fusion we have this type of evolution with inflammatory discopathy under the fusion, and so we need to correct our balance, and we must done an osteotomy of L4 to engage a better balance. So concerning DDD, for us, there are few indications for fusion before the total disappearance of the disc. The instability and all kinds of stenosis, with or without decompression, are good indication for our dynamic stabilization device. Local and global kyphosis are real contraindication for dynamic stabilization and need to be reduced and fused. So I thank you for your attention. Thank you.
Nuevamente, muchas gracias por su excelente presentación al profesor.
It is time for us to listen to our next talk from Engineer Matthias Roller from Germany. He'll be talking to us about the conservative treatment of osteoporosis. Muchas gracias. Quiero, primero que nada, llevarlos de la mano sobre este tema de un tratamiento conservador de la osteoporosis. En Alemania la osteoporosis, más o menos tenemos 6.3 millones de personas cada año, que es bastante de pacientes. Hablando de 885,000 al año. La osteoporosis es una enfermedad sistémica incurable. Debemos de progresar, de detener la progresión de esta, porque
problems, so we need medication, lifestyle changes, surgery, exercise, sport, and braces are also a part of the therapy. I want to start with the braces. Nowadays we work a lot with dynamic bracing. So if we have a stable fracture, what we have often in osteoporosis, you can use a dynamic orthosis. If you have an unstable fracture and you want to treat it conservative, you need a fixation orthotics, or for sure you do the surgery. How dynamic bracing works, it's based on a biofeedback principle. So it's the patient itself becomes a biofeedback. It's like somebody is always behind you. You go in a bad position, in a sagittal position. He puts you back in a good position. So the patient have to go actively to the good position. And it's also a new programming of the brain, because if I have a bad posterior in the sagittal field, so it's in my brain and it is as a normal situation. But if I get a push in a better position, it's a reprogramming of the brain. So braces are bringing relief, influence, and the static shifts the main stress points. So you see here, these two Bavarian men doing also the same. Maybe they have some influence on the neurological system if they are on the way back and emptying the beers. This is a very interesting paper from Pfeiffer. It's randomized, and you see how the group who used the dynamic space braces, increasing the back muscles strength, increasing the abdominal muscle strength. So it's a very interesting outcome, I would say, for bracing. It's kind of a mobile fitness gym. It's really worth to read the whole paper because this is a very interesting study. Braces in sports are friends. So this is always a good match. And not all kind of sports are suitable for building bones. So often you hear, if you have patients, they affected with osteoporosis, the doctors or others said, yeah, go swimming, go hiking or cycling. This is good for the cardiovascular function, but it's not good for the bone growing. So you need a little bit more impact to the bone to bring the bone to grow. So better is sprinting, weightlifting, boxing, judo, karate. They are all sports for elderly people, I guess. It's the best sport you can imagine. So is it possible for the 70-plus osteoporosis patient to do a weightlifting, kickboxing? For some, yes, but for the majority, no. So that's why I think it's very important that they have a possibility to have performed with large force and peaks to greater effect on the development of the bone mass, but they need exercise they are able to do in these ages. So the 5 Esslinger is made a special program for geriatric patient. You don't need any machines or anything. It's the only body weight is enough to train, and it's really suitable for patient 70 plus and older. Get the strength, the power, the balance, and the flexibility. There are the components you need for treating osteoporosis. Another very interesting thing is the vibration therapy. I don't know if it's very well known in Mexico. This is a highly frequent therapy, and if you want to increase the muscle strength, increase the muscle mass, increasing the endurance, the body shaping, you need a high heart frequency from 25 to 40. If you want to muscle relaxation, pull down, or balance training, you need a very low heart rate so that they have to balance on this plate. Very important as the plate is reciprocal. So you find plates that go up and down. They are not so bad, but they are not as effective as a reciprocal ones. So and it's very easy to do, and the training is very effective because it's time consuming. 5 minutes or 3 minutes on the plate with a high frequency. It is like a 10,000 meter run, what the muscles have to do. So also people with other affected problems, orthopedic problems, can do this. So there are a lot of studies out there. So this study is done in a nursing home, and it was really increase of balance and mobility. A very interesting study is the bed rest study. they simulate a Mars mission, and they put healthy people in the bed for weeks. And one group trained with the vibration therapy in the bed, and they showed a really less muscle mass reducement. So if there was a pill that had many good effects as physical exercise, it would be on the breakfast table every morning, also on my breakfast table every morning. But we don't have this kind of pill yet, but I think it would be good. So osteoporosis and the risk of falling is always coming together, because a weak muscle becomes a weak bone, or a less bone tendency. And the weak muscle is also a weak performance of the gait. So there is an assessment where you can assess how high is the risk of falling of your patients. And if you have a higher risk of falling, you need a conservative treatment. So this is one part, the racing test out of this assessment. So the patient have to go up and down without hands helping, 50 centimeters box or chair. And if they can do this 5 times afterwards, it's good. And this is a scale. Another test is the posterior capacity test. If you like, you can do it. So you can stand up and make the test for the posterior end. But if you like, you can do it with me, and then you can go up and go to the semi-tandem. And if you do this, you can do it. Feel free. So then you see what you need on phalanx and the muscles. And if you then close your eyes in doing it, then you see what you have to do. And if you are 80 years old, it's a really difficult thing to do. And if you have a tequila test behind you, it could be also like feeling 80. So, and then in the tandem gait, if you go 8 steps forward and backwards on a line, you can try this at home or with your patient. And you make this, you are able to do this, you have a half of a risk of falling compared to your age. So this is a very simple test. You can do it in 5 minutes, and you see how is the situation of your patient, and do need your patient maybe more rehabilitation. So treating osteoporosis is more than just curing a fracture, and I think it is a systematic disease, and we have to really look in a wide view on it. Thank you very much for your attention.
Muchísimas gracias al ingeniero Roller. Y
It is now time for us to listen to a new speaker who's joining us online. So we'll be having a video conference. Let's see how this is going to be rendered. It is time for us to listen to Dr. Cheng Lilin from Taiwan. He'll talk to us about the usage of IBMBA, or implant-based mechanical vertebral augmentation. And he'll give us a clinical perspective. Probando cabina de interpretación. Probando cabina, ¿me escuchan? Probando cabina, ¿me escuchan? 1, 2, 3. Aumento vertebral.
Bueno, gracias al profesor Chen Lin y a continuación vamos a tener
Thank you, Professor Chen Li. Now it's time for our coffee break. We kindly ask you back at 11:25. Thanks.
Buenos días. Por favor, para ir tomando asiento, hubo un cambio en el programa.
Good morning. This has been a change in our program. Dr. Derman has to leave shortly, so we are going to start with the endoscopic section right now. And after the section on endoscopy, we are going to move on to the Q&A session for the morning session, along with the endoscopy section, and we will close with the case discussion. So thank you so much for staying with us. And now I am going to wait just a few minutes before we start with Dr. Peter Derman's presentation. Dr. Derman is in the Texas Back Institute that we know. This is a landmark center for spine pathologies. And obviously they perform around they perform fusions and disc prostheses, and Dr. Derman is the only one who performs endoscopic spine surgery. Of course, we know that his colleagues such as Dr. Ziegler, Blumenthal, and other colleagues always refer to Peter. Peter is an enthusiast of endoscopic spine surgery. He is also involved in research and education and topics related to spine surgery. So I will now yield the floor to Peter Derman. Hola a todos, muchas gracias por recibirme, es un gusto para mí estar aquí. El día de hoy voy a hablar acerca de por qué deben ustedes de adoptar el tema de la cirugía endoscópica de columna. Es un tema que a mí me encanta, yo estoy seguro que a muchos de ustedes también.
Here we go. Here are my disclosures. All right, so we're going to go through some of the high points, and I have some bullet points about why you should adopt endoscopy. But we all know what this is. Waking up early in the morning, walking around the hospital, seeing all your patients, checking on their wounds, asking them about their pain control, listening to them complain. We all love this, right? No, we hate this. I hate rounding. I don't want to round, and I don't round anymore. I very rarely round, and that's because 70% of my patients go home the same day, and the vast majority of those are endoscopic spine patients. So I'm not one of the guys walking around early in the morning in the hospital. So first of all, this was an easy one. No rounding. That's the first one. So great for the patient, but also great for you. And why don't you have to round? Why do patients do so well? And it's because you're not creating a bunch of collateral damage. And this was one of the very first cases I did, probably in the first 10. And it's a lady who was like 70-something years old. She had a severe radiculopathy from a disc herniation. She wrote this without being prompted on the internet, and I took it here. So she had endoscopic spine surgery in 2019. First case in the morning, home the same day by noon, on the elliptical the next day, right? So my partner's patients are still in the hospital. My patients at home on the elliptical at the gym. No pain anymore, other than some soreness around the incision. And I wanted to bring some attention to that soreness. That's the way that very consistently these patients who are post-operative spine patients are describing their post-operative pain. They call it soreness. And they often say it's not even bad enough to take medications. Oh yeah, my back's a little sore. Thank goodness my leg feels so much better. And it just makes your life as a surgeon so much more pleasant when these are your post-operative interactions. Here's another early case that I did. This was actually one of probably my first 20 cases, and it was on the former president of my group, so no pressure. I did not sleep the night before this case. He had the misfortune of having a 2-level foraminal disc herniation and rip-roaring, horrible radiculopathy, and this is a tough guy. So I did a 2-level transforaminal endoscopic discectomy on him. It went really well, and this was the closest thing to having spine surgery on yourself, but it's even better. You could do it on your partner, and he could tell you what it feels like. And so he was texting me along the way during his recovery. So first, post-op day 0 in the recovery room, amazing improvement, you're the best, but still maybe a little anesthesia in his system, so I couldn't celebrate yet. Then post-op day 1, he texted me he'd slept the best he'd had in weeks. You know, he had some soreness, but not enough to take acetaminophen, right? So like, can't be that bad. And then post-op day 2, he texted me. He walked 3 miles that day. He'd walked 3 miles the day before. He saw a full day of clinic the following day, and he did a full day in the OR the day after that. And he has not looked back since. And this has probably been 4 years since this surgery. So, you know, this is the kind of outcomes that you can really only get with endoscopic spine surgery in this setting. This is a video. Hopefully it plays. It might not. Can you play the video? Maybe not. It's okay. It was, maybe we can play it. Yeah, can you press the bottom left? So this is a patient. The top screen is him before surgery. The bottom screen is the morning after surgery. And look how well he's moving. He's home, of course. And he sent me this footage just to show just how well he's doing. I guess this is the closest I get to rounding, which is patients, you know, texting me and telling me how great they're doing. Just moving around and back to normal. He was in so much pain before. And again, the reason that patients do so well, it's not rocket science, is you're not creating a bunch of collateral damage getting to the spine to do the work that you need to do. So you're leaving no trace. The MRI panels that you see on the right side are from a woman who had a right paracentral disc herniation at L5-S1 with very typical S1 radiculopathy. I did an endoscopic discectomy on her, and then unfortunately, she was in like a minor motor vehicle collision like 2 years later, and somebody ordered an MRI. And by the time she got to me, she was totally asymptomatic and it was fine, but it was a nice opportunity to check my work. It's always kind of cool to be able to see what you did. And you can see that the disc herniation is not only completely gone, but you can't even tell where I was or how I got there. Did I go transforaminal? Did I go interlaminar? Did I go over the top? You can't tell because the soft tissues and the bone is all completely intact, which is why these patients do well. And just for everyone's knowledge, I did a right interlaminar approach endoscopic on this one, but you can see the muscle looks exactly the same. Here's another one, very similar story. This is a young lady who had a previous traditional left-sided microdiscectomy at L4-5 by another surgeon. She subsequently reherniated and was sent to me because this is a great setting for endoscopy. And the images on the top are my pre-op images, and you can see there's a recurrent disc herniation on the left there. And I did a transforaminal endoscopic revision discectomy on her. This is a great solution here because I didn't have to traverse the previous scar bed. I could go right through the foramen. I didn't have to take any additional bone. And, you know, we don't want to get into their facet joints. This is a young lady. If she herniates again, you know, I'd like to avoid a fusion. She might be a lumbar disc replacement candidate, and I want to avoid taking away more and more of that facet joint. So I did a transforaminal discectomy. She did really great. Like 2 years later, she was in a fender bender and got an MRI in an ER somewhere and brought it to me. It was doing well by the time she saw me, but again, opportunity to check my work. You can see in the bottom 2 panels, there's no disc herniation anymore, and there's no disruption that's visible in the soft tissues. So, you know, these are the kind of things that reinforce my conviction that this is the way to do it if you can do it this way. But tubes are small, right? I used to do all of my decompressions through Metrix tubes, and don't get me wrong, these patients with tubular decompressions also do very well. They go home quickly, they don't have a lot of pain, but as a surgeon who is doing exclusively tubular decompressions and has switched largely to endoscopic decompressions, I can tell you that there's a substantial difference. Like, the difference from open to tube is the difference from tube to endoscopy. And at first you're like, well, what's the difference? It's an 18 millimeter tubular retractor. It's just 1 centimeter less for an endoscope. Why does that make it any difference? Well, 8 to 18 is not that much, but if you look at the cross-sectional area, it's not about the diameter, it's about the area. So, the cross-sectional area of an 8 millimeter endoscopic working tube is about 50 millimeters. And for transfemoral, it's only a 7 millimeter tube. But say 50 millimeters, for an 18 millimeter tubular retractor, it's more than 5 times as much. So there really is increased damage that goes on. And yeah, maybe we're splitting hairs a little bit, but if our goal is to be as less invasive as we can, this is the way to do it. So you can take my word for it, you can look at my MRIs, you can look at my geometry there, but really what we need is research. And a lot of the pushback that I get on endoscopy is that, well, the studies don't show that it's superior to other ways of doing things, either minimally invasive or traditional spine surgery. And a lot of that problem is coming from 2 things. One, we just don't have a lot of good data yet and good publications yet. And 2, a lot of the publications are looking at time points that are essentially irrelevant. Are patients the same 2 years out from surgery? Yeah, they probably are, right? Like they've healed more or less from the soft tissue insult by 3 months, 6 months, a year, 2 years. Those are the time points that a lot of the existing literature is looking at. But what really matters is what's happening the day after surgery. Is a mother able to take care of her kid 2 days after surgery? Is a working person back at work 3 days after surgery? And those things are not captured in the existing literature, and they're important. So in the United States, we have an endoscopic spine research group that we've put together recently. And what we're doing is we're really trying to address this research gap by publishing good data so that no one will be able to deny the benefits that we all are seeing. And one of the main tools that we're using is a phone app that allows us to track the patient's progress essentially daily after surgery. And so we're not just seeing the patient back in 2 weeks and saying, how you doing? Oh, you're doing great now. I know how my patients are doing. I get a dashboard on my phone every single day after surgery in the immediate postoperative period, and then to some extent even out to 2 years. And this is how I really think we're going to demonstrate the benefits that we're seeing with endoscopic spine surgery. We're already starting to publish. We've been doing this for about a year or 2. This was one of our first publications, Pain Alleviation and Functional Improvement, ultra-early patient-reported outcomes. That's what we're talking about here. So here we pooled our data, and we were looking at discectomy patients, and then I'll show you the data for decompression patients. And what you see on the left is their VAS leg scores, which is that essentially immediately their radiculopathy goes away. Which is oftentimes what we see with traditional or minimally invasive decompressions. I mean, radiculopathy surgery is very rewarding surgery because patients wake up and their legs feel better. But the second panel you see is their back pain. And what you can see is very rapidly their back pain's going down. There's not an increase in back pain after surgery because we haven't done all this damage. And by day 3 after surgery, they've already gotten full recovery of their back pain. So they're as good as they're going to get already only 3 days after spine surgery. Now, interestingly, ODI, or function, takes longer to improve because these patients are debilitated before surgery, and they actually improve in their physical function even up to 90 days after surgery, but they're not having pain. If we look at decompression patients, kind of a similar thing. So these are stenosis patients. The first was discectomy, this is stenosis. And those patients get immediate improvement in their lower extremity symptoms. Their back pain lingers a little bit longer, probably because these are a little bit older patients. Maybe there's a little bit more work that needs to be done. But they get full improvement in their back pain as much as they're going to get by 7 days out from surgery. So even a week out, they're there. And then also up to 90 days after surgery for functional improvement in ODI. So, second thing, why endoscopy? Because the patients recover quickly, and that's our goal. How about this? We have a lot of large patients in the United States. Hopefully, you guys have less, although I don't know. I practice in Texas. Everything's bigger in Texas except for me. This is a patient of Dr. Telfian's. He's one of our endoscopic spine research group partners. He practices out of Brown, and he wrote up this paper where he talked about how to operate on extremely heavy patients. Hopefully something you can avoid, but something that sometimes we have to do, and it's not fun for anyone. One of our recent ESRG papers that's come out has looked specifically at this. So what is the impact of obesity on endoscopic spine surgery? And what it shows is there's very little. So I don't like to advertise this, so don't tell anyone outside of this room, but it's actually not any harder to do surgery on really obese people with the endoscope. In fact, sometimes it's easier because the fat holds the scope for you, and it's less work for you. So what we looked at is we pulled our data, we looked at 55 obese and 65 non-obese patients and just compared their outcomes. We had no infections in either group, which is not surprising. The infection rate for endoscopic spine surgery is something on the order of 1 in 10,000. There was no difference in blood loss or surgical duration, so you can get this done just as fast. And there was no difference in outcomes at 90 days. And then interestingly, and I don't exactly know how to explain this, the obese patients actually got their gains more rapidly. So nonetheless, you can do surgery on obese patients much easier without additional risk associated with kind of more larger open approaches. Here's an abstract. It hasn't been published yet, but it's going to be presented at the joint section meeting later this month along the same lines. So this is not just obesity, but we also looked at ASA, American Society of Anesthesiologists classification, age, and then also obesity, and looked at our 90-day readmission and ED utilization after endoscopic surgery. And we had almost 800 patients here. So our sample size is really increasing, and we're going to be able to show some really powerful things. And basically, our ED utilization was about 7%. A lot of it was people that just went in for pain control and then were given some medication and left. Actual readmission was less than 2%, and so was reoperation rate. And interestingly, ASA, BMI, and age had no effect on these rates. So you are able to operate on older, sicker, more obese patients if you have to without elevated risk with endoscopic spine surgery. So it's like kind of the great equalizer. So another thing, less risk for high-risk patients, a reason to think about doing this. Here's another topic. I operate in Dallas, Texas. That's where I'm from. There are 300 spine surgeons in Dallas, Texas, which is about 275 too many. It is extremely, extremely competitive market where it's very hard to differentiate yourself. Well, anyone can claim they're a minimally invasive spine surgeon. There's not really a definition for that. And when I first came to town, there were certainly surgeons that were making their incision 1 millimeter smaller, still doing open surgery and calling it minimally invasive. So it's very hard to differentiate yourself in that kind of environment. However, you really can't call yourself an endoscopic spine surgeon unless you're an endoscopic spine surgeon, I guess, unless you're lying. And patients want this. So this is a study done by Albert Telfian and some others around the world where they looked at how far the average patient traveled for their surgery. And in the United States, to Brown, that's where Telfian is, that was just over 90 miles. In the Netherlands, it was 287 miles on average. And in Germany, that was 103 miles. Now, these are mostly discectomies and laminectomies. This is commodity surgery. Any spine surgeon should be able to do this. And instead, these patients are traveling hundreds of miles in many cases, past hundreds of spine surgeons to get these surgeries. This is me, and this is a single day in my OR. This is my record. I had a patient travel to me for surgery from Alaska, and another come to me from New Hampshire, which is about as far as you can get and still be in the United States. And they both came to me passing thousands of spine surgeons. And so if you're in a market where it's difficult to differentiate yourself and you're trying to build a practice, this is really a great way to do this, and it has really allowed my practice to blossom in this competitive environment. So patients want it. They don't even necessarily know what it is, but it sounds cool and they want it. Okay, what about the learning curve? This is like the elephant in the room. Okay, this sounds great, Derman, but I hear it's really hard to do. I'm very comfortable with what I do. I didn't get exposed to this in my residency or fellowship training. This is a really scary thing to do. It's a totally different paradigm shift in how we're doing surgery. Well, just to let you know, the first endoscopic case that I ever saw, I was doing. So it is possible to do this and do it safely. There is a learning curve, though. And what the literature, as well as my own personal experience, shows is that the learning curve is all about time and not about safety or effectiveness. And that's a really, really important point for me. Because ethically, learning something outside of a fellowship training program on my own, on human beings who entrust me with their care, I take very seriously. And if I'm going to be putting them at risk by learning on them, then I don't feel comfortable doing that. But that is not the case. So you are slower, but you are still safe and effective. The graph on the right, it's not from my study, but my data is similar, shows a learning curve for a transforaminal endoscopic decompression. And what you can see is that first case there was almost 300 minutes long. But then the surgeon rapidly gets better. And that mirrors my lumbar learning curve too. So my first lumbar case was a chip shot paracentral interlaminar discectomy at L5S1, like literally the easiest case you can do. And it took me 3.5 hours. Nothing bad happened. I made gradual progress throughout the case. It was just slow. But the lady woke up and she went home and she felt great and she did well. And then I got gradually faster every time, actually rapidly faster. I remember spending 45 minutes during that first case looking at a tubular structure and trying to figure out if it was the traversing nerve root or not. And it turns out it was an epidural vein. But you only have to spend that 45 minutes one time, and then you know what a vein looks like, and you're rapidly a lot faster. And so I think it's really important to come into these cases with realistic expectations. Your first cases are going to be slow, but it's very rewarding as you go forward that you get faster and faster and more comfortable. And if you come at it with that expectation and being excited about that challenge, you rapidly get a lot faster, and it's rapidly just the way you want to do these cases. So what are those early, easy cases that you should start with? Well, first thing you want to start with is soft pathology in readily accessible areas. So what is that? So for the transforaminal approach, there's two major approaches, and we'll talk about technique later. But for the transforaminal approach, which is really an outside-in approach, the easiest stuff to get to are foraminal disc herniations at L4-5 and above in the lumbar spine. And the reason for that is by the time you dock, you basically dock your endoscope in the foramen, you are looking at the disc herniation. And realistically speaking, you dock, you pull out some stuff, and you're probably mostly done. I mean, you're going to spend some time ensuring that you see all your anatomy and that you've done an adequate decompression. But for all intents and purposes, you've done the job there. Now, the reason at 4-5 and above and not at 5-1 is because the iliac crest and the pelvis can get in the way at L5S1. It doesn't mean it's impossible to get there, but it's not an early starter case because you have to work in a narrow window around the pelvis. So 4-5 and above foraminal pathology. Easy stuff for transforaminal. Interlaminar approach would be a paracentral disc herniation at L5S1. And the reason that is easy is because the interlaminar window at L5S1 is usually enormous, right? And so what you're really trying to do is exploit existing bony windows so that you don't have to remove bone, because removing bone is slow, and also you want to preserve anatomy if you can. And so, for an interlaminar approach, going at L5S1 is a very easy starting point. I don't think that transforaminal or interlaminar, one is necessarily easier than the other. And in fact, I think that it's paramount that surgeons know how to do both of them, because it's like trying to put a round peg in a square hole if you're just doing one of them. So I would just, if you're looking for your first endoscopic case, look for whoever comes in first, an interlaminar for 5-1, paracentral disc, or a foraminal disc above it. And then you can gradually tackle more and more difficult pathology. So, that's L5S1 transforaminal, that's migrated disc herniations, stenosis cases, and then you can get into the cervical spine, which is like one of my favorite utilizations for endoscopic spine surgery, thoracic spine, fusion, etc. And as you work your way down this list to the more complex stuff, this is where endoscopy even shines more, right? Because not only are you doing a less morbid approach, but in many cases you're doing like a completely different surgery, avoiding fusion and other need for instrumentation. So these are kind of the easy cases you want to start with. Oh, and here's the cervical learning curve. So Dr. Hofstetter from the University of Washington and I published our own learning curves for cervical foraminotomies. And what we found almost precisely echoed the lumbar learning curve literature, which is that you're slow when you first start, but you're just as safe and effective as even when you get good at these. Our learning curves, interestingly, were slightly different. I kind of hit a plateau after my 9th case. It took Dr. Hofstetter a little bit longer. He hit one at 29 and then 49, but this is not because I'm a better spine surgeon than him. He actually did his first endoscopic cervical case after only 5 lumbar cases, which is like really aggressive. I waited till I'd done 50 lumbar cases before getting into the cervical spine, which allowed me to kind of mount that curve a little quicker because I was used to moving my hands, used to looking at things. But look, this guy did only 5 lumbar cases and was already safely doing cervical spine surgery. So it just goes to show that you can do it. So, next thing, you can safely mount this learning curve. It is definitely learnable. Let's go through some cases. So, first case here is a 29-year-old male with right L5 radicular pain and weakness. And he had tried, extensive conservative care, injections, etc. And he came to me as a third opinion. One surgeon had told him he needed a TLIF. One surgeon told him he needed an ALIF, and he really didn't want either one of those things. And as you can see on his imaging, x-rays are relatively normal, maybe some early disc degeneration at L5S1, but he has a right-sided foraminal far lateral disc herniation at that level, which is causing his stenosis and his symptoms there. And you can see his pelvis is narrow. There is very little space between his iliac crest and the facet joint there. And so, before I was doing endoscopy and I was doing these with tubular retractors, I honestly don't know that I could have gotten there. I don't know that there's a 16 or an 18 millimeter window to get there from a paramedian approach. So my plan here was to do a transforaminal endoscopic discectomy. And this was actually probably one of my first 20 cases. So, I said that, a far lateral transforaminal at 5-1 is not a good, easy starter case, but once you get some reps, it's very doable. So, I went outside in. I was able to get all the way out there. I could directly visualize the exiting nerve root, and I cleaned out around that area. This is the disc material that I removed, and these are his pain scores. So these are his VAS leg scores. You see he had, 6 out of 10 pain immediately before the surgery with weakness. That went down to 2 out of 10 within a couple of weeks, and then down to 0. And he had complete resolution of his motor deficit as well. And if you look at the dates there, that was 2020. This was, almost 3.5, 4 years ago. This young man is still doing well and is still walking around without screws and rods in his spine. And that makes me proud, right? So it's not just a smaller surgery, it's a different surgery. Here's another example, case number 2. Here's a 66-year-old lady who is extremely active, loves CrossFit and working out and stuff like that, who developed an acute left L4 radiculopathy. And what you can see is she had a foraminal disc herniation on the left at L4-5. Interestingly, once you start doing transforaminal surgery, you spend so much more time looking at the foramina. And I find that I see things and nuances of foraminal pathology that I never really appreciated before. But nonetheless, she was really, really uncomfortable with all this pain that she was having. She'd had expected non-surgical care, and she was coming to me for surgery. Now, obviously, she has an adult scoliosis here. And so there are surgeons who would say, hey, you know, in order to access this, I need to take down the facet joint or a substantial amount of the facet joint. I'm going to need to fuse this level. This is within a scoliosis. And maybe she needs a T10 to pelvis, right? Or maybe she gets a one-level fusion, but is more likely to need a T10 to pelvis down the line. Obviously, you know what I'm going to say here is we did not do any of those things. I did for her a transforaminal endoscopic discectomy at this L4-5 level. Took 0 bone whatsoever, so she's not destabilized in any way, and was able to remove that disc material there. And what you can see at the top is the exiting nerve root coming across with that shadow underneath it showing that it's now decompressed. And here are her scores. So she had her surgery. Again, this was in 2020, so you know we're going on 3.5, 4 years ago. Continues to do well. She's actually like my #1 fan. She, writes on all my social media accounts about how well she's doing. So, nonetheless, as soon as surgery was done, I mean, her back pain, her leg pain, and her ODI normalized, and she's continued to do well. And I cut her loose. She's doing CrossFit, and she doesn't have a T10 to pelvis. Here's another one. So this is an interesting one. We're going to get a little bit more complex here. So this is a patient who had an L5-S1 fusion by someone else and fractured off a bit of the posterior end plate of L5 into the lateral recess and the foramen. And you can see that really on the axial view there, that piece of bone that's hanging out there where that exiting L5 nerve root needs to be. She had pain, but was kind of milked along non-surgically for a few months. And so by the time it got to me, it was no longer like an acute fragment. It was probably 3 or so months out. So what are your options here? Well, she's fused, so it's not the end of the world to take down the facet joint. But removing that scarred-in piece of bone ventral to the dura is not a lot of fun, right? So what you might do is just try a dorsal decompression and hope she gets better. But that piece of bone is really pushing. The other thing you could do is try to mobilize everything and drill out that piece of bone ventral to the dura. But that's a pretty harrowing thing to do. Maybe you're braver than me, but I don't like the idea of doing that. So what I did was an interlaminar approach. And I did a little hemilaminotomy, just enough to get in. I was able to identify that bone fragment. And one of the wonderful things about endoscopy and this interlaminar approach is if you can mobilize the neural elements, which actually wasn't too difficult here, you can use your working cannula to give yourself 360-degree retraction and protection. So I have no qualms about drilling out calcified disc herniations ventral to the dura, pieces of bone like this, because once you have your working cannula in place and you're protected, your blood pressure goes down to, totally cool as a cucumber, and you can really, with total safety, drill anything you want out. So this is a postoperative CT scan you see here, and you can see I've totally been able to remove that fragment there. And then this is kind of cool. What you see in the video is the actual cage. So it was a tie-coated PEEK cage. You can see the titanium there, and I've drilled out all the way down to the cage, proving to myself visually that there's no more bone there. And she similarly got relief of the associated symptoms. Here's another kind of interesting one here. So this is a young man, 34-year-old gentleman, with 3 months of right L5 radicular pain and weakness. And now he had disc herniation at 4-5, and a run-of-the-mill, with some caudal migration causing his L5 radiculopathy. But the interesting thing is he also had a lytic spondylolisthesis at L5-S1 that had never really been symptomatic. He had some back pain here and there, but never enough to go to a doctor. That was not really his problem. His problem was this acute disc herniation. And the fact that it was caudally migrated gave me some pause. So, if I was going to do this either open or through a tube, I would likely have to take down some of the top of L5. And my concern would be, would I destabilize or contribute to destabilization of his lytic spondylolisthesis at the level of below, which may be symptomatic someday, but it's not presently. So I thought a very clever way of getting about this was to do a transforaminal endoscopic discectomy. And this allowed me to go transforaminally at L4-5, so I didn't touch the L5 lamina in any way. And I was able to get in and reach down and decompress that nerve root there. And you can see me pulling out that disc herniation. Like many of these patients, he got immediate resolution of his pain. He took 0 medication after surgery. He was like a construction manager, and on post-op day 1 was like on construction sites working full-time. And eventually went back to total full activity. And it's been more than 2 years, and he continues to do well. Someday he might need something at L5S1, but he's only 34. So if you fuse him now, you're just looking at for something down the line. So I thought this was a unique scenario where this really changed what he might have gotten. Here's another one. We all run into this. This is a 73-year-old gentleman with 3 months of right anterior thigh pain, so upper lumbar radiculopathy. I hate doing these from the back. Through a tube or open. The anatomy is very narrow. The facet joints are very sagittally oriented. It is very difficult to get a large central-ish disc herniation out from the back without destabilizing the patient, And so many people would do a TLIF here or another kind of fusion, and that's not wrong. But if you can do it without destabilizing the patient, that's obviously in their best interest. And so this is another good use for transforaminal surgery. So here I went from the right side, and you can see in these fluoro shots that I was able to get past midline with my scope and even see and directly palpate into the contralateral lateral recess and some out the foramen of the other side. So you can really get central pathology here without having to worry about destabilizing a patient. And similar concept for thoracic discs. So this is a great tool for thoracic discs. And you talk about the delta between an open surgery and endoscopic surgery. You do a thoracic disc through a thoracotomy, that's a really morbid surgery. You do it through the endoscope and they're home the same day. And so this patient did very well. Here's another one, gift sent from a partner. So this is a 67-year-old woman who had very severe spinal deformity, and my partner, who is an excellent deformity surgeon, did a massive scoliosis correction on her, and she actually really loved it. She felt so much better. She could stand up straight. She had actually much less back pain once she got over the initial hurdle. But she had a painful right foot drop since the surgery. Like, she woke up with a foot drop and right leg pain. And, my partner tried to see if it would kind of calm down. He got her some injections and things like that, try to get her out of the woods from this big surgery. But she continued to improve overall, but not with this foot drop. So ultimately, he imaged her. And what you could see is at the L4-5 level, his lateral cage was maybe a little bit posterior and in the foramen a little bit. No judgment. It's a big surgery. He's a very good surgeon, but things happen. So a little bit posterior with the cage, and then a little bit of the end plate of L4 had broken off, or maybe it's an osteophyte, and was hanging out in that foramen there. And that's what was causing her L4 radiculopathy. So at this point, she's like 4 or 5 months out. The thought of going back, trying to reposition that cage, it's pretty stuck in there. I mean, there was BMP in there. It is not going to move very easily. Another option would be to do a dorsal decompression, but you might have to take the rods out. These are long rods. It's a big surgery to do that. Or try to work around them and just dorsally decompress it. He was hoping not to do any of those things, so this patient arrived in my doorstep, and the thought was, hey, maybe I can do it without any of those things. So what I did was a transforaminal approach at that level. And what you can see on the top left video is that posterior lateral corner of that lateral cage. And I'm palpating that piece of bone that had also broken off. And those things were deflecting the exiting L4 nerve root upwards. And so what I did is I took a diamond drill, and I basically just drilled out the cage, drilled out that corner of the cage. It took a little bit of time, but I was pleasantly surprised that the diamond drill could take down this titanium 3D printed cage. And then I was also able to remove that piece of bone that had come out and was hanging out in the foramen. So that middle view there you see is me drilling the cage. My OR staff said it looked like glitter or confetti in there, and that I had bedazzled her foramen. So now she has a bedazzled foramen. And then that far right view is after I had drilled everything down and removed the bone fragment. And you can see that there's plenty of space, underneath that nerve and before you get to those structures. And she's done so well, so I'm really proud of this one. I'm happy for her. And then here's the last one that I have. This is a 44-year-old gentleman who had acute left C8 radicular pain and weakness. And this comes back to cervical. I mean, I love lumbar. That's how I got into this. That's why I got into this. But my favorite cases now are my cervical cases. Because really, this is a place where, again, endoscopy really shines. I mean, doing posterior cervical surgery, people have a lot of pain. Which is why a lot of people do disc replacement or ACDF instead of posterior when they can. But the beauty of the endoscope is you can get in there, you can do a foraminotomy, which is what I'm going to do here, discectomy, and they have remarkably little neck pain. So it's kind of the best of both worlds. So this guy has a disc herniation on the left at C7T1, causing the left C8 radiculopathy. And this is I'm going to walk through some of the steps here. So using fluoro, and about a 8 millimeter incision, I dock over sequential dilators my working channel. Oftentimes in the lower cervical spine, cervical thoracic junction, you can't see anything on the lateral, especially in stocky patients. So I do a lot of the targeting on the AP. So once you're down, just to get you oriented, the head's to the left, the feet are to the right, medial is up, and lateral is on the bottom of the screen. And the surgery is really the same surgery as if you were going to do this open or through a tube. So the steps are the same. You're just doing it in a less morbid fashion. So what you're seeing here, and you can see the circle on the diagram and the cartoon on the bottom is where my tube is. You're seeing that interlaminar V or interlaminar Y, where the left C7 lamina meets the left T1 lamina. And that's really your bony starting point. Once you find that point, you know where you're at, and things tend to go really smoothly. So the next thing you do is you can take a drill. There's a variety of different kinds of drills, fluted drills, more aggressive drills, protected drills. In the cervical spine, I like to use a diamond drill because it's very safe and not very aggressive. And so what you do is, just like a regular foraminotomy, you take down a little bit of the IAP of the level above. You can do that with the drill and then with a kerrison. And below that, you're going to find the SAP of the level below. And I like to take the IAP, in this case of 7, all the way to the tip of the SAP of T1, because you don't want to leave any of that residual SAP in the foramen. If you do, you can have some residual foraminal stenosis and ongoing symptoms. So you can see I'm moving my tube, and you can see there's space above that SAP of T1, showing that I've gone high enough. And then the next thing you're going to want to do is you take your drill and your kerrisons and take down that SAP of T1. I drill it until it's super thin, and then I use a kerrison for the last layer. That's a little bit of that process there. And underneath it, lo and behold, you get this beautiful, beautiful view of the thecal sac and the exiting nerve root. And at this point is where I'm like pulling in people from the hallway. I'm like, look how cool this is. Look how beautiful it is. And you can very safely work underneath the nerve and remove disc herniations if necessary. If this is just dorsal stenosis, you're done before then. You just decompress them dorsally. But I find that I've got really nice visualization and the ability to address ventral pathology as well. And then you can kind of palpate and make sure you're all done. You work above the nerve, below the nerve, etc. And then this is my favorite part of the case. Because of the angled optics of the endoscope, you can actually look back toward yourself. So you turn the endoscope 180 degrees and you get this out-of-body experience where you're actually looking back toward yourself through the foramen. And you can really assess what you've done. You know, you can see the pedicle sloping away and know that you've gone to the lateral border of each of these pedicles. This is actually a picture from a different case, but it was just a nice view that I had of that nerve going out that foramen. And you can see the pedicle above and the pedicle below, and there's nothing touching that nerve anymore. You can be very, very confident that you've done an adequate decompression. I also take x-ray, so I know that I'm from pedicle to pedicle and out the foramen. I save the disc material and make sure that I can correlate that, if there is a disc herniation, with what I see on the MRI, so that I have an idea that I'm done. And then this is what the patient's neck looked like, you know, once the incision healed. You can barely even see it there. Here's some more examples of patients who had to get re-imaged for some reason, not associated with my surgery. One guy had a cardiac problem, and I forget about the other one, but you can see one's a right-sided foraminotomy, one's a left-sided foraminotomy, and I was really able to open everything up without sacrificing a substantial amount of the facet joint there. So just a few more notes on endoscopic foraminotomy. Obviously, there's less soft tissue disruption. One thing that can be annoying with foraminotomies in general in the neck is that venous plexus often bleeds a lot. And it can be hard to see, and it's just not clinically significant bleeding, but it's unpleasant to do the case. But actually, with the endoscope, the fluid pressure from the endoscope tamponades that bleeding, and there's actually much less bleeding. So the visualization is just way better. The ergonomics are better. It's just a much more comfortable surgery and more pleasant surgery for everyone involved. Those angled optics provide improved visualization around corners, as I was talking about. And then this is really interesting. So a greater ability to undercut the facet joint. Because the endoscope's only 8 millimeters wide, you really have an increased ability to drop your hand toward the midline and undercut with a kerrison or a drill that facet joint. And there's a study, I have the reference here, where they actually quantified the amount of foraminal expansion and the amount of undercutting that you could do, as well as the amount of facet joint that was left. And what they found is that you could get a comparable foraminal decompression, comparable expansion, while resecting less facet joint because of your ability to undercut. And that was compared to both tubular and open foraminotomy. And then from an outcomes perspective, the data shows that they are similar long-term and tend to be superior short-term because patients bounce back than doing this in other ways. So just to summarize, why should you do endoscopy? There's no rounding because your patients bounce back really quickly. You can do this safely in high-risk patients. These patients want it, and if you want to be part of the future of spine surgery and you want to set yourself apart now, this is a great way of doing it. You can learn this safely, and then there's all kinds of cool things that you can do once you get comfortable with endoscopy. So I like this slide. The best view comes after the hardest climb. There is a learning curve. When you first start, you're going to look at a lot of this red screen that you see at the top there, which is bleeding, and it's slow and it's tedious. But as you get better and better, you learn how to preempt these issues, and you just get a beautiful, beautiful view. Thank you very much for including me in this meeting. I have some social media sites, including a YouTube page. If you're interested in endoscopy, I talk a lot about that. And then these two videos that I showed here are actually full-length videos that I posted, one of an interlaminar discectomy and one of a cervical posterior foraminotomy endoscopically, start to finish. And so those are really nice tools if you want to watch these kind of cases. And as an added bonus, I narrated them with my 5-year-old son, who's really cute and asked some good questions. Thank you very much. I appreciate your time.
Thank you, Peter, for being here. Since you are leaving already, we're going to take just a couple of questions from the audience. Vamos a hacer un par de preguntas, él se tiene que retirar. Entonces, nada más si alguien quiere hacer alguna pregunta de la audiencia.
Hola, ¿qué tal? Gracias. Thank you very much for your wonderful
No tiene.
technical question. I noticed you use Joymax endoscopic, and la pregunta, pues, the question is, the water flow that you use, how high is it?
How high is the flow?
Yeah, like, I think Joymax uses like percentage, like 30, 50%. And the question to how high you
Very good
always
question.
test?
Yeah, good question. I keep the flow about 45. That's kind of my number. The main goal is you got to keep it below the diastolic pressure because you don't want to be causing venous congestion and things like that. So I just keep it easy. I keep it always at 45. I never turn up the flow. But there are instances where you transiently might want more fluid pressure. So those are, one, if you get some bleeding, it can be helpful to have higher flow. The way that I handle bleeding is, one is I will move the endoscope closer to the site of bleeding because the fluid comes out of the tip of the endoscope. So if you just push it closer, it increases the local fluid pressure and can help with bleeding. The other thing I do is I'll occlude the outflow valves transiently, right? So there's no flow out, and so just for a few seconds or a minute or something, there's increased flow into that area. You can also use like a topical thrombin. I'll inject some thrombin and stuff like that. So those are instances where it could be helpful to transiently increase the flow. I don't do it on the machine because I'm worried I'll forget to turn it back down. The other time where it can be helpful sometimes just transiently to have increased pressure is like if you're taking a sensitive bite around the dura. And one thing I didn't talk about is, uniportal. We talked all about uniportal today. It's a whole nother talk about biportal. But uniportal, you only kind of have everything's all in line. And so to retract for yourself, your fluid actually acts like a second set of hands. It's really nice. It pushes the dura away, right? But sometimes if you're taking a really sensitive bite with the kerosene, I'll occlude the outflow valve again to push a little bit more fluid and push the dura away so that I can more safely take that bite.
Gracias, Pierre. ¿Alguna otra pregunta?
Gracias, Peter. Gracias por la presentación.
Nuestro siguiente ponente, Alexandre Simonin. Algún tiempo.
An honor and pleasure to be with you. Great talk from Peter. It's quite a practical talk. I will show you a lot of videos. I hope you will not get bored. So I come from Sion, which is south of Switzerland, middle of Europe, but we don't are really part of Europe community. So we talk today about full endoscopy. Maybe some of you don't really know the differences. So we actually use an endoscope, and we can have the camera, which is a HD camera, on the top of it. And there is a working cannula where we place the endoscope through, and we can pass tools in a hole inside the endoscope. There is a water flow and to go in and to go out. It's a bit an evolution of the matrix tube, and we spoke a little bit about the matrix. The difference is that we can still have our retractor, because the endoscope is inside the working cannula, which is a retractor, But comparing to the metrics, we have the camera on the top, so at the end of our instrument. We can pass the instruments through it like a metrics tube. We have continuous irrigation, which is a very good and interesting point for infection rate. And there is light, the light source at the top of our instrument. And importantly, we can move it, which is quite different from the metrics tube, which was really attached to the table. I will not speak a lot about biportal endoscopy. Biportal is like uniportal, so you have an endoscope. The difference is that you have to do another incision, so a second incision. I'll not show there, but you have to do another incision to place your instruments. The advantage is that you can use your usual instruments like your microscopic Kerrison punch, the drill that you use with your microscope. The disadvantage is that you are not working inside the endoscopes and it's not a retractor system. So every time you pass an instrument, you have to go through the muscle, through the skin. It's a little bit different, probably easier to learn at the beginning. Many companies, they are more or less the same, and the rep working for companies, actually, they work before for other companies, so engineers as well. And there is also a big marketing about uniportal, biportal, multiportal, so you can argue, okay, you can pass the instruments through your endoscope, you can do a stab incision, pass the instruments through the stab incision, through both, which is multiportal. The most important problem, I would say, and we discussed with my colleagues about it, is this is disposable. This is the RF probe you need to buzz the bleeders. And this tool, you can use it only one time, so one per patient, and the price is between 500 and 1,000 euro. So you add this price to the case, and that's why clinics, they are a bit reluctant, and some surgeons are a bit reluctant to start, because it will be more expensive than microscopy. So I have a few videos. This is just, the quality of this one is not so good, just to show you that in case you're going interlaminar, and it's a small window, so you see I have to remove a little bit with the punch. Okay, I did a stab incision and passed my microscopic drill. So is that uniportal, biportal? Actually, it's a uniportal endoscope. I just did a stab incision and went with my drill at the tip of my endoscope, and I enlarged my window. So don't make a big deal about uniportal and biportal. I think you can do biportal with uniportal. The opposite is not true. The Eospine did a great work by classifying all the procedures you can do. Full endoscopic is uniportal. Endoscopic assisted is biportal. So it's not full endoscopy, it's endoscope assisted. If there is only, I think Peter gave you a lot of reasons to start if you didn't yet. If I can give you one reason, is the infection rate. So literally, there is no infection with endoscopy. Probably for many reasons. One of them is the continuous irrigation. Of course, it's very minimal invasive. There are several papers showing that. In our practice, so we started now to do all the cases through endoscopy, and we didn't see any infection. And in the past, like every one of you, I had 1 or 2% rate infection. It's always a bad thing when people come back with after a stenosis surgery with some wound infection or a spondylodiscitis after discectomy, and this can be avoided. I will talk a little bit about the two possible approaches, which are the interlaminar approach. So you can see here, it's a natural space. You can go between laminas with your endoscope and reach the pathology without drilling any bone. Of course, it depends on the anatomy of the patient. The other window, natural window, is the transforaminal window. So this is a little bit less in surface, but it's also a very, very good window where you can work and access several pathologies. As Peter said, I think it's good to learn both techniques. Why? Because if it's a pathology that is quite medial, you can reach it with interlaminar window. If you want to go lateral to the recess, it's probably better to go transforaminal, and then there are some exceptions. For example, if you have a big disc herniation in the middle, like he showed, I will show you some examples as well. L5S1, those are better for transforaminal. You want to start with this interlaminar case, probably L5S1, like Peter said. So it's like a lumbar puncture. So you will go directly and reach the disc without drilling any bone. And the typical starter case is this L5S1 disc herniation with a big window. Big windows means not only craniocaudal, but also the length of the lamina laterally should be quite long enough so that you can reach and see laterally to the sac without hitting the facet joint. So the facet joint has to be not too medial to permit the access to reach the disc fragment. When you master L5S1, you will go to other levels. Sometimes you have to enlarge a little bit the window, so we have drills, as you saw. We have also punches. So step by step, of course, you introduce your first the working cannula around a dilator in the interlaminar space. So you can feel the lamina a little bit like in Matrix, and then pop, the yellow ligament. Don't force it too much. You can place it under lateral X-ray to be safe. Then you remove the muscle, identify the yellow ligament, and you start cutting it. So you do a cut. You don't have to remove the yellow ligament like you would do with the microscope. You just make a cut. A tip is to turn a little bit your endoscope so that you can see the tip of your scissor. To go laterally, it's better to have the angled scissor, as you see here, so that you will have less risk to hit the dura. When you reach the facet joint, sometimes if you go a little bit more cranial, you can take this extra bite, which will permit to go lateral to the neural structures. In this video, you can see the turning maneuver. This is the turning maneuver. As you can see, the working cannula is turning. It's a beveled working cannula, and it will protect neural structures. If you go to endoscopy courses, they will show you this technique. I don't do it anymore. Why? Because you introduce your working cannula not only in the epidural space, but you go next to the dura, to the disc. So you introduce a working cannula that is 7 millimeters of diameter next to the dural sac in a canal that may be 1 centimeter, 1.5 centimeter. It's quite, to me, dangerous. I don't do it anymore. Now I keep my working cannula epidural, and then you can reach the disc with the dissector, mobilize it, and take the rongeur and take the fragment without going with your working cannula inside, really, the canal. The other beautiful window is the transforaminal window. It's a hard anatomy, and I think most of you do the pyramid and Wiltse approach, so you're a little bit familiar with it, but of course the structure at risk is the exiting nerve root. And I think it's really important that you have, when you start this, a proper technique. As said Peter, there is a learning curve. For me, this learning curve was much more easier and faster because I had mentors around me. So one for interlaminar, another one for transforaminal, that both are old surgeons that did it 20 years ago and then started again because of the new technologies. I think it's very good that you have, if you start, someone that knows the procedure, because you will earn time and probably be more successful. The main thing to do is, for transforaminal approach, you do the approach with a needle. So you will place your entry point according to the pathology, and I will show you. And then you do an incision already so that you can place the working cannula and the endoscope afterwards. But you start with the needle, and the needle has to hit the SAP, the ventral part. So you're sure that you are really at the most safe part of this Cambin's triangle, which is the posterior part, so the SIP. And of course, inferior, this is the safe part, this is the dangerous part. So ventral and cranial is dangerous, caudal and posterior is safe. So we tried it on the cadaver, and it's really good. I encourage to go on the cadaver lab. So here you can see a cadaver dissection. So this is midline. So we are left side. It's a bit difficult from here. Picture there. So you can see the exiting nerve root, which is number 3 there, the pedicle below, the pedicle above, so cranial is on the left of the image. And basically, you can see that it's a natural space. We placed our working cannula inside, and you see that there is space. So I said you have to target the pathology and design your entry point according to the MRI. So it will not be the same if you want to reach a pathology that is really in the midline at an upper level where maybe you have the kidneys, or if you want to go below when you want to reach a pathology at a different level. Maybe it's a little bit more foraminal, like in this case, so it's not outside the foramen, it's really foraminal. If you want to go for L5S1, you have to think about the iliac crest with the star here. So some people said, okay, I can drill through and place my endoscope. Some people did it, but then you're locked inside the bone. So I recommend still to go medial from this iliac crest. The trick is to come a little bit from above. So if you come from cranial and you go caudal, the iliac crest will be less cumbersome. A good thing to do is when you do the approach with your needle, you first hit the ventral part of the SAP. So you're sure you're at the safest part of the Cambin's triangle. And then you plunge into the disc. So you know you're really inside the safe part. And when you reach the disc, it's a good thing to do this injection. So we use a mixture of methylene blue, 1 cc of methylene blue, iopamidol, so contrast agent, 1 cc, and 1 cc of saline. 3 cc is largely enough, even less. And so your disc will be, you're sure you're inside the disc, checking on the X-ray. And when you will be in the surgery, you will know that the disc is there because it's blue. Another cadaver video showing you that this is the beveled working cannula. And in this case, it's a cadaver with a swollen root, very narrow space, though it's not reality, but still, it shows you that when you do the approach, you first put the needle, as I told you. When you did the discography, then you will put the dilator, and then you will put your working cannula. And you see it's going clockwise. Why? Because if you go counterclockwise, you are more at risk to hit the exiting nerve. This is also something important. Always go clockwise when you enter with the bevel first on the SAP, and then you go clockwise, advancing inside the disc. An example of L5S1 extraforaminal disc. And you see, even if there is some blue, methylene blue a little bit away, usually the fragment is really blue. Why? Because you inject inside the disc, and the product, it goes where the path of least resistance is. It means through the annular defect to the disc fragment. And then you can, when you remove the fragment, you are reassured because it's really blue. If you, at the start, I gave too much. I injected a pure methylene blue, and one of the patients, he urinated blue. So I said, oh my God, I put the methylene blue in the kidney or something, but actually not. It's the normal way of eliminating the methylene blue, and some people, they do it for fun at Halloween. So, other applications, so this is also, like Peter said, I think those big discs inside the canal, it's a great indication for transforaminal. It's actually less risky. Why? Because you avoid neural structures. You can argue, okay, I can do a very wide decompression, so I can retract the dura safely. But of course, you can avoid this by going ventrally. In this case, you have to drill a little bit of the SAP, because if not, either you will have to take a very lateral entry point, or you will not reach enough the medial part of the disease. In case you are a big fan of seeing everything, I mean the dural sac, the roots, and so on, don't start endoscopy, because most of the time you will not have a very clear view and will not be so sure that you remove all the pathology. But it's a question of pressure. So if you see that you remove a large volume, you must be confident the patient will be fine. They are fine, even if you didn't see the root. Another example of this transforaminal approach for medial pathologies. Again, so of course you have to do a few X-rays, and at the start probably a lot. So this is to consider. And now there are some navigation systems that you can use with different companies. We use RivoSpine. They have a tracker system that we don't have yet. But if you have a ORM navigation, you can place a reference on some tools. In case you want to reach really medial pathologies, sometimes you have to do you have to drill the facet. In this case, there was, I don't know if you saw it, this is the drilling, the amount of drilling, so very little. It seemed big, but it's not actually. There was a dural tear. At the start, I was panicked, so I opened everything with the microscope and stitch, and now I do nothing, because actually there is no dead space, so the fluid will not accumulate somewhere, and it will not leak to the skin. So if you have a dural tear, unless you did a big trouble with the rootlets, then there is nothing to do as well. But if it's just a concern about the leak, don't be concerned. Of course, people said, okay, there is less instability with, I go rapidly through the papers, but of course, you destabilize less. Adjacent segment facet cyst, I will not go for fusion. I will always try a direct decompression using the endoscope. I keep the fusion cases for like lysis or some specific indications. And of course, after the try of direct decompression. It's not so easy because you don't have your two hands. So it's not so easy to separate things, and that's why I think intradural pathology is probably not so well for endoscopy, because you only have one hand, the other one is holding the endoscope. But you see, you can still use the RF probe to dissect and remove the pathology. If you do lumbar stenosis, of course, it's a little bit more time-consuming because the drill is not so efficient than the usual microscopic drill. And if you do biportal, probably you're a bit faster for the drilling part. But the good thing with full endoscopy is that you can do a single incision and reach 2, even 3 levels, because the lumbar lordosis permits to angle, and with the same incision, you can easily reach 2 or 3 levels. It's not just a matter of skin incision. I think it's a matter of muscle damage. You saw the beautiful pictures several years ago. You don't see where the surgery took place. It's not only the MRI, it's the tension band, all the muscles, and we have a lot of people here concerned about this. Of course, you can do 3 levels as well. And one beautiful surgery, and I think Dr. Dubois spoke about this foraminal stenosis this morning. And I think one of the best treatment for it is remove the part of the SAP that is compressing the nerve root. And so you go transforaminal. And in case you have navigation, it's good to use navigation for those cases because the anatomy is really tricky. But you can see the facet joint. You can, if you start like me, that was one of the first cases, probably you want to identify the facet joint and then you drill all SAP. If you're a bit more confident, or if you have the navigation, you can just drill the ventral part of the SAP and enlarge the foramen. And actually, it's true. It's a dynamic pathology. When people stand, this SAP, the piece of the SAP will hit the nerve. Why? Because the facet joint, with the age, the degenerative process, the facet joint is not stick together, the upper and the down facet. And that's why this part of the SAP is going to the nerve. Of course, endoscopic fusion is also a possibility. I'm a big fan of anterior and lateral approaches, like many of you here. So I keep it for a few cases where the anatomy, for example, you have really anterior psoas mucocine with all the vessels in the covering the disc, so you don't want to go anterior or lateral, old patient. And now we use this setting, so we have navigation or arm. You can stick the reference frame if you don't want to do an incision, and you do the acquisition. We distract on the screws with, this is a Medtronic Space D retractor system, and then you place the cage through the transforaminal incision. If you are a big fan of T-leaf, I would recommend go for it, because this is the new T-leaf, MIS T-leaf. It's less invasive than you could ever think about. Technically, we put the reference to the drill. You can choose another instrument, but you can place it there. And we place this cage, which is like expandable in both axes. Not the best implant, so I would not recommend to do fusions through endoscopy yet, because the implant is not like you could have for an A-leaf or a X-leaf, but you can well see the prep, the end plates, so it's something you can add to your armamentarium. Cervical foraminotomy, I think Peter showed you beautiful videos. I will not go so it's the same. If you did it with the microscope, you will love doing it with the endoscope, because of the muscle that you will not have to cut. So this is a very, very, very good approach, and people will not complain about this muscle soreness be freezed for several days like you would be with a microscopic approach. One of the best also indication, and we spoke about it briefly, is thoracic disc. And actually, it's completely changed the way I manage those thoracic discs. They are not so often, it's quite rare. We have probably one case per year. Maybe some of you guys have more, but you can go above the rib. In case you could also go between the ribs, but I recommend going above, because it's already enough lateral. If you drill the SAP, you can reach very medial pathology. Of course, you want to avoid going through the pleura, so it's better to follow just the rib and then drill the SAP, and you see, you can reach even the contralateral side. And you go ventral to the dura to remove the disc pathology. Again, if it's a very calcified disc, probably it's more difficult. You should go the most lateral you can, drill a big part of the SAP. In this case, it was not too much calcified. And in the end, you can see the vertebral body, the contralateral side. The post-op MRI is fine, and the patient is great. So that's true. Post-op day one, they are walking like this and very little scar. What else? Many other applications. You can place odontoid screws. You can see the longest colli muscles and drill and place your Kirchner wire through the endoscope. Complications. That's my last few minutes. I think it's important to talk about the complications. And if you start, I would like you not to do what we did wrong. This is impressive. You can see a big retroperitoneal hematoma. In this case, we did a transforaminal approach, which was really lateral. We hit the intercostal, probably, artery. And then it was an old patient, and she lost some blood. And she was monitored, and we gave her some blood. And actually, she was not reoperated. And in the literature, we don't recommend to reoperate, because you will have a lot of blood loss, and someone that already lost probably 1 or 2 liters of blood. We tried also with the radiologist to do embolization, which was not possible. So it's sometimes something that is impressive, but usually it's self-containing. The most important thing is this turning maneuver. I would not recommend, and if you go to courses, they will say, okay, you introduce your working cannula, you turn, and and that's not a good thing to do. Oh, that was another thing. You can use Surgiflow. They have laparoscopic applicators, very long, very thin. So in case you have some bleeding, especially for cervical foraminotomies, because of the bone bleeding, you cannot apply bone wax easily. So sometimes it's better to use a little bit of Surgiflow. That was what I wanted to tell you. It's the fact that you enter the working cannula in the spinal canal. This is for the interlaminar approach. I don't recommend. I think we should stay epidural and not going through with the working cannula, because not only it's 7 millimeter in a 1.5 millimeter canal, but also you don't have this haptic feedback. When you have the assistant, or you were assistant retracting the nerve root with the nerve root retractor, you can feel how much pressure you put. When you turn the working cannula, I don't have this haptic feedback, so you may get into trouble. Thank you for your attention.
Muchas gracias al doctor Alexander. Le entregamos un presente de parte del comité organizador. Gracias. A continuación vamos a tener la plática del doctor.
We are going to have the presentation by Dr. Raúl Rincón, who will also discuss endoscopy. He is a neurosurgeon who is working in Los Cabos in Baja California, Mexico, and he will share with us his experience. Hello, good morning, everyone. To conclude this section devoted to endoscopy, for those of you who may not know me, I'm working at Los Cabos. I've been living there for almost 8 years. I was the first neurosurgeon to open shop at Los Cabos. Now I have new colleagues, and we are located at the tip of the peninsula in Baja. This is our hospital. And to your right, it is the largest building. And right next we have a Hampton Hotel. Let me point it. And over here, there is the Narrow Spine Clinic, which is where we work. So this is excellent location for our program of foreign medical tourism, particularly patients coming from U.S. and Canada. We have expanded our services, and we have patients not only for endoscopic surgery, but also lumbar disc prosthesis, cervical, ALIF, instrument, percutaneous interventions, larger reconstructions, cemented screws, cervical prosthesis. I have no particular conflicts of interest for this talk. Now, what is the objective of a surgery as surgeons? Which is our objective? Well, we want to be able to solve any issue causing the least damage possible. And what we don't want is to leave any sequela to the patient, where we want to preserve healthy structures, talking about muscles, joints, ligaments, and not just looking at the damage we can cause to nerve structures, which are, of course, our main area of concern. But of course, we have to think about healthy structures and preserving them. So we have to think about the patient's safety, but also ours as surgeons. From the endoscopic perspective, all of the equipment that we have used have evolved in time. So around the 80s, we only had a monoscope. And so we now have different diameters, different lenses. And we know that is our working channels, and we also have different lengths We have endoscopes that are designed to work more around the cervical spine, which are shorter and favors maneuverability, but not just the lens, because we have 4K HD, we have 3D for transitions as neurosurgeons, where we are used to microscope. And to make the transition for my orthopedic colleagues, they are more used because they perform arthroscopies. So as neurosurgeons, sometimes it is difficult for us to work at that depth, but there are now special 3D cameras that offer the option of having length. And now, obviously, we now have these lenses. We have new technology. We have different devices. We have different types of clamps. We have dissectors. We have burrs. We have angulated burrs, diamond tip burrs. So we are opening the option, the technological option. And now we have the fusion topic, which in Mexico we do not have the right arsenal. We are just beginning to develop the right instruments for an endoscopic fusion. In terms of approach, we have the transforaminal, and it is important that our landing point will be different from a conventional foraminal approach. So the target will be more targeted towards the inferior pedicle. And this is giving us the possibility to go to the right area that we want to approach without causing any damage in the surrounding structure. So what we want to prevent is damaging the root. So we have interlaminary approaches that, of course, the disc hernias are the most frequent pathologies from the endoscopic perspective, and of course the technique has evolved, and currently the number of publications has increased exponentially, and we know that much of this has to do with our Asiatic colleagues, and the majority of spine surgeons in Asia perform endoscopic approaches. Some of them are specialized only in endoscopic approaches, so they have had extensive practice, and of course, because of their healthcare system, they have been able to explore this area further. But of course, there are other applications, not just disc hernias, but also facetary cysts, foraminal stenosis, and also a narrow lumbar canal and how to decompress it. And even in cases with the spondylolisthesis, as long as there isn't any instability, but once we check there is no instability, we can decompress without compromising stability. Adjacent segment disease, when there is a stenosis, and then we can decompress, and also lumbar fusions and infections. I will share with you some cases, but those of us who are devoted to endoscopic surgery, of course, we are opening the options for interventions. And this is a classical radiculopathy that will not improve with conservative management, and this is an interlaminary approach, which is a classic. And these are my favorite surgeries because this is a quick surgery, clean, direct, without damaging healthy structures. And here we are dissecting the dural sacrum, and this is how we can pull hernias, as you can see, pull them out, and we truly enjoy doing this through the through a very nice approach. Of course, these are the most beautiful surgeries. Of course, not all endoscopic cases are like this one. And here I dissected going below, and so I was able to grasp and extract the fragment. Here you can see how we are dissecting, how we are luxating, so to speak, the fragment with a soft but constant traction in order to extract the fragment. But if there are any remnants, we can go back and pull them out. And we are extracting by the working sheath. And so as Alexander was saying, in Switzerland, they use RF, but here in Mexico, we use our low frequency cannula. But here once I have extracted the fragment, I go to the disc and try to seal the lesion. And here you see the nerves that are decompressed, and we can also visualize from different angles the area where the herniated fragment was. And so if you want to start doing endoscopy, this would be the ideal case when we have extruded fragments in L5S1. But we can also work on cysts, such as this one that did not improve with conservative treatment. This patient loves hiking, and she had a severe radiculopathy that was a disabling condition, and we decided to go for this approach. You can see the yellow ligament that is hypertrophic with internal calcifications. These are the membranes of the cyst. We opened, we cleaned, and resected until we visualized the dura, and then we simply ended up cleaning with the same RF and removed the fragments with the clamps. We started removing any fragments, and this is how we are proceeding, and we go cleaning posteriorly, looking towards the facet. And this is the dural sac, and it is a very direct access. There are other types of facet cysts that are harder, and here we need to work more on the bones. This is one of my favorite drills because I can angulate them. Of course, I will come in straight, but in the handle, I have the possibility to angulate the burr. And so I can treat other areas that perhaps with a straight drill, it would be more complicated. So here I'm going towards the ascending facet. We resect the bone, and actually the work at the bone is very little. All of the red lines that you see there, that is the cyst. And as you can see, it's hard, and the patient had a rather severe radiculopathy, a limiting radiculopathy with a pain level of 10/10. And that very same day, or the next day, because as protocol, we always infiltrate with anesthetic with a little bit of morphine. And actually, this has worked for us great for the handling of the post-op pain, and the patient leaves the hospital with no post-op pain. We have decompressed the dural sac, and you can see how we thinned the yellow ligament. And this was a chronic situation where it was really causing way too much pain to our patient. There are other complications that there isn't much literature about it. Some of us as surgeons have moved this topic a little bit further. We have a Castle B2A. This is a 17-year-old male who was training to football to become a football soccer player, and he had presented lumbar pain with a suspicion of this pseudo articulation of an L5 left, and right. I'm sorry, because when we made this blockade, we first did an anesthetic a blockade, and then we performed a second blockade to confirm that the patient was going to be benefited by a surgical intervention. In both cases, it was positive, so we decided to resect and remodel. And in this image in the transop, what I'm pointing with the pin is the trajectory of the L5 root. And it is important to bear this in mind because think about a 17-year-old patient who is planning to become a football soccer player with a drop foot. Well, it wouldn't be the desirable outcome. So we planned surgery. And so this is what we are looking for, and it is precisely what is dark, and this is what we want to resect. And here, to the right of the video, in the transop, you can see the sacrum, and we are working with the drill, remodeling, until we reach the iliopsoas fascia. So we remodel patiently. Want to pay close attention to the medial aspect where the L5 root is located. And this is something that we really need to watch closely. And of course, we don't want to go deeper. So we now have remodeled. You can look at the transfers process, and the patient fortunately is fully encompassing his activities, his sports activities, pain-free. Because we removed what was causing pain. There are other cases, such as this foraminal stenosis. We first performed a diagnostic blockade to determine whether that nerve root was causing the issue, and of course we had to perform also a physical exam, but we had a blockade to perform a blockade in order to confirm our diagnostic. We perform an endoscopic decompression, and I opted for a contralateral trajectory. If you can see, the decompression goes straight. And here we're going to the lateral right recess, and I opted for a sublaminar approach with going towards the right in order to have a better visualization of the foramen. And here we decompress the yellow ligament. This is the dural sac. And I would like to point out that this patient had several epidural blockades before. So, and this is important to point out because of what I'm going to show you in a minute. But here you can see the facet, and this is the facet towards the right lateral recess, and we are decompressing this area, and you can see this chronic arachnoiditis that the patient had. So we are releasing the area with the RF and scissors. So we are releasing the area, of course, being very careful so as not to damage the dura. And of course, these adhesions will limit the mobility of the dural sac or the root and contribute to chronic pain. Other applications, such as this case, a patient with discitis that did not improve with empirical treatment, and the we decided to perform an endoscopy with transforaminal approach. We can see the pus, and this, of course, helped us control. We had a very specific diagnostic. We were able to determine the pathogen, and we could control infection because of the constant irrigation of water that helped us clean the area. And we are not showing in the video, but here I am. I um, I am working in the space of the disc, and I am irrigating the area in order to extract as much debris as possible. And so this gave us as result that it was Mycobacterium porcinum that was causing the issue here. So this is a good strategy for a therapeutic diagnostic. This is an 87-year-old patient with a very precise stenosis, a discopathy of the entire lumbar spine. Of course, our intention is not to perform a fusion. His pain was very precise, so through an interlaminar approach, we decompressed the left side until we released the dural sac and going towards the left lateral recess. In other cases, such as this L5S1, here we have a fusion. This was a case I worked on about 3 years ago. And in Mexico, we did not have the right equipment to prepare the area. I have just a couple of cases with fusion, but to date, I have not found a frank comparison with a conventional mini T-lift. So far, I work with a mini T-lift, or in this case, I decided in this case for a posterior approach because I wanted to decompress the foramen because it was very stenosed. And with an A-lift, I wouldn't have been able to fully decompress. So that was my rationale. And here I am placing a conventional 8 mm cage, bullet type. This was 3 years ago in 2020. The patient now is doing fine. She's very pleased with the result. And what is important to point out, something that discouraged me to perform this type of surgeries without the right technology is that the patient developed a post-op radiculitis that lasted for about 4 weeks. So this is not something that we want. Of course, he was able to recover completely, but we do not have the right technology, a cage with the right surface, right contact for an adequate fusion, the right tools to prepare the disc. So I decided to pause this. But the advantage, as well as the T-lift, that is, it's good for the tissues and the internal structures. And to conclude, take-home messages, as with any medical field, we need to have the right diagnosis. It is the key to have the right diagnosis. We can see the pathology, we can look at the x-rays, we can look at the MRI, but we need to know exactly what is the cause for consultation. And obviously, we need to work and solve the patient's issues. So this is why we need to treat patients' symptoms and not base our decisions only on images. And of course, we have to try to be as conservative as we can in our approach. Or if we need to use a brace, if possible, well, that's even better. But when a patient requires surgery, we have to be as conservative as we can and preserve the healthy structures as much as possible, the muscles, joints, and ligaments. And of course, when we talk about endoscopy, well, endoscopy can open new horizons because it truly changes our perspective regarding spine pathologies. Perhaps you may not specialize on this 100%, but what is important is to be able to identify the cases that could benefit it by endoscopy. So these are my contacts. This is my contact information. If you care to share one of your cases with me, please do not hesitate to do so. And this is all for my part. Thank you. Well, we thank Dr. Rincon, and next we are going to have a roundtable discussion with this morning's presenters from the two morning blocks. So I would like to have the presenting professors to join me, and I invite you all to open your apps so you can ask questions through Slido. Thank you.
Well, they are telling me now that if there is anyone that would like to ask a question to a specific doctor, well, there's no issue. You may just ask for the mic and you may say it out loud. Thank you. I'll just ask you for a favor. Please make sure you ask questions in Spanish. The doctors will be having translation devices, so they'll be getting the version in English. So please make sure that everybody understands in the audience in Spanish. Thank you very much. And Dr. Alfonso Garcia from the city of Tijuana. My question is for the morning intraspine part of the program. When do you recommend using the artificial ligament, and when only an implant as a standalone implant?
So if I'm doing a unilateral approach, so if I was doing a microdiscectomy, then I would be preserving their normal ligaments and not using the artificial ligament. If I was doing in an older patient where I was doing a difficult central decompression, I would sacrifice the midline to make my decompression easier. That means I can be more facet sparing, which is good. And then your intraspine can then just be dropped straight into that space where you've made your decompression. And remember, the ligamentum flavum has been removed as part of your decompression. And then in that situation, I would use the artificial ligament. Very important. And then that recreates that tension band posteriorly, which will protect the disc inflection.
¿Alguien más que desee hacer alguna pregunta? Bueno, pues les agradecemos a los profesores.
That'll be all. Thank you very much to all the speakers. Thank you for your kind attendance here, for your very interesting talks. And this is the end of our Q&A session today. Thank you very much, and get a round of applause for them. Thanks of all. Thank you very much. And now it is time for us to have another talk. We'll be having the clinical case presentation from Dr. Rios, which is the last talk of our program this morning. To resume with it, please, Dr. Daniel, would you come to the front? I'll yield the microphone to him. Oh, Dr. Daniel is there. Dr. Daniel graduated from the National Medical Center from the western part of the country. He has been trained in spine, and he's an orthopedist. He is going to present a clinical case. Morning, everyone. Sorry, because I thought we were going to be stay longer in the roundtable session, but that's what happens when we are live, right? Thank you very much. It's my pleasure to be here with you. All of us here in the audience who are the ones that really wanted to stay here. I will really thank you to stay here a little, to stay put a little bit more. But this really corresponded to the previous segment of mobility preservation. However, let's start with the presentation. Sorry, this is not working, I guess. Here we are. First, let me tell you the case of a lady that was 26 years old. She has a professional degree, and she works in a private hospital in urgencies. She has no degenerative chronic background, previous surgery that was a leak post-culture, no traumatic incidents or toxicomanies. She is 77 kilograms, weight 174 meters height, and she trains in the gym for 5 days a week. And the liposculpture came along with a recent loss of weight that she wanted to have because of aesthetic and health issues. She started with lumbalgia with systematization on the right leg. After a couple of weeks of evolution, she has a 7 out of 10 EVA from that is predominant while walking, especially when making flexion and extension of the spine. In the physical assessment, she walks independently, upper guard on the right, sensibility without alteration, and the strength of the limbs with Daniel 5-5 score. These are her images. And if we can see there is no grade or big deal, probably lowering the height of L5 and S1 only there. At that point with these images, nothing else caught my attention. So I would like to ask the following question. Questions that were given before, the same way we did before. Please, I'll ask you for your participation, answering 1, 2, 3 about the initial diagnosis. What is it that you suspect? Is that a discal degeneration, a mechanic lumbalgia, or a facetary syndrome? 1, 2, or 3? Would you please answer? Sorry, you are all asleep. Isn't it open? Yeah, it's open now. Let me go back so you may have the questions again. Okay, this might be a discal degenerative disease, mechanical lumbalgia, or facetary syndrome. We have no evidence, but only the images, of course. So, degenerative discal disease is the one that is a prominent one, and some other people are talking about the facetary disc. All of them are alternatives, and they might be correct. However, let me go back. So in order to reach a correct diagnosis, which complementary studies would we ask for? A dynamic set of X-rays, EMG, or CT scan, or MRI, all of them, but there's no option for all of them. But now let's take a look at the results. Thanks. So apparently the majority is asking for dynamic X-rays. Back to the presentation, please. I guess we did have them. And we decided to have an MRI. There are some dynamic X-rays. There's no trace of instability, no displacement of the segments. What we see here is that there is an herniated disc with the rupture of the fibrous part that practically covers half of the channel, and that's why the patient has these symptoms. As a physician, I had to talk to her and discuss about the different options of treatment that we had. Initially, we proposed the following. Number one, about a treatment, we developed, first of all, having a conservative management, ALIF. Number 3, microdiscectomy. Number 4, discectomy plus an interlaminar dynamic device. And 5, an endoscopic discectomy. Based on what we've discussed throughout the Congress, we have talked in detail about each of these treatments. So which would be your way to go, the treatment you would propose? So option 1, has it been updated? I guess it's the previous one. You could update your answers there in the application, right in the application. Let's see. So let's do it the old-fashioned. Who would go for the conservative management? Raise your hand, please, by show of hands. Please show who would go for number 1. Number 2, who would propose an ALIF to this patient? ALIF. No one. What about the microdiscectomy? Would you go for that? Raise your hands, many people. Discectomy plus a spacer, the dynamic interlaminar device. 4, 5, 6, 7 people. And final endoscopic discectomy. Endoscopic specialist, okay? Okay. At the beginning, we decided to start slowly. So we gave her a conservative treatment because the patient did understand properly the natural the progress of the disease, and she decided to wait for a couple of months to see what happened. We had no indications of a neurological problem, talking about a neurological deficit, etc. So she wanted to avoid surgery, and okay, she called it for physical activities. She started a neuromodulator with a muscle relaxing medication. There is alarm. There's a discussion on Kinus Coda, and her symptoms improved. She gets an EVA 2 out of 10. She says not blocking because she's got a good result after the treatment. But a month and a half after starting the treatment, she started with an acute amount of pain with no improvement in analgesia or a painkiller. We didn't make her undergo an MRI once again because it was quite evident that she had discal extrusion. So we went back to an evaluation of the treatment she was going to be given. So at the second step, what about the question? What would you recommend? First of all, continue with the blocking and probably the conservative treatment. I'm sure this is not going to be popular. Second position will be ALIF. 3, microdiscectomy. 4, microdiscectomy plus an interlaminar dynamic device. 5, prosthesis of the lumbar disc and CISC, and an endoscopic discectomy. What is the option you would go for? Here we can see how this endoscopic discectomy is the winner. Oh, but there are some other options that are too close. Oh my goodness, They change a lot. Option number 5, the lumbar disc prosthesis. Number 3. If you see practically all the options, I mean, at least some people here would have implemented them. So that means that this is something that shows that the election of a treatment among the spine surgeons is based on the symptoms, the diagnosis, and it is also related to the techniques you are more familiar with and the way we have previously solved situations like these ones. So what the doctor was proposed was a right hemilaminectomy with an interlaminar spacers at the level of L4 and 5. After having her understand, and since she was a health professional, the idea was preserving her capacity to move and avoid discarthrosis because it was probable that it appeared. Among the different options that we know from different spacers, we use the one that was presented this morning because of the position that it might reach within the laminate. So it is important to remember that we need to place it at the top. I mean, as much as possible, and a bone has to be resected in a contained fashion. Of course, I have had the case that one of these spaces moved to the channel, and it led to a very, very severe problem. So I also consider that for this specific girl, she wanted to go back to physical activity soon, and she was being trained on weightlifting. This could be an option that could preserve her from further damage. About the post-operative progress, she started walking the same day with no more pain at the level of the buttock or the leg, only with the vision analog scale equal to 3-4 out of 10, with a paresthesia on the lateral part of the knee toward the leg. Probably she started having a neuromodulator for 2 months, and probably a little bit longer. She reported only the usage of neuromodulator for 2 months. But 2 years afterwards, first I got the CT scan from this girl, and there was no problem. She was working in a private hospital, and they were calibrating the CT scan device, and she decided to get a CT scan. And she continued exercising Williamson Mackenzie's exercises, and she was satisfied after surgery. The CT scan seemed to be interesting because it indicated us that the device kept being in an interlaminar placement. And coming back to the other one, that there was no erosion in the spinous structures, and there was no other data that there was a possible structure or any subchondral sclerotic position in this or disease in these structures. I mean, it was okay. This is something I wouldn't have asked to any other patient without any symptoms. As a conclusion of this case, 4 years after the procedure, the patient continues without any symptom. I talked to her a week ago, and she said that now she is on body mass index of 28. Now she does less. She exercises much less, only once or twice a week. She keeps exercising on William and Mackenzie's only with this frequency, but she refers to be very satisfied with the procedure. Originally, she wanted to study to be a cardiologist, but now she is very happy with this. These are some X-rays that she took last week. And these were taken in the same hospital she's studying currently. Now we can discuss a little bit about all these different procedures. I should have added an endoscopic discectomy, A-leaf, lumbar disc prosthesis, instrumentation, T-leaf, microdiscectomy. Is there any other possibility?
Are there any questions or comments? I'm sorry, without a microphone, we cannot translate. The truth is that you resolved the issue adequately. We stabilized this young patient. Yes, it's just this comment that the solution that you provided was adequate. Are there additional questions or comments? Is Dr. Richter around here? Well, I have a question and also a comment. My question is, did you use a unilateral approach, and did you use a minimally invasive approach? Well, I use a tubular retractor, the ones that can be opened, and then I removed the tubular retractor because I used a medial approach in order to be able to place the spracer. Was this unilateral? Yes. Now, always the ideal in these cases, and I first want to congratulate you for the case that you shared with us. And my comment has to do with this technical aspect. When you have a lateral hernia with no significant facetary issue, that you can approach with a tubular approach for your approach, and then you can use the spacer. Technically, I personally, I do not morselize at all. I'd rather not morselize. I have been using the same technique for different years. I have been modifying, of course, we know that in time there can be erosion, particularly in women that in age will start presenting bone loss or that gain weight. There may be an erosion of the device. So my recommendation would not to touch the spinous process. Yes, I've had to remove spacers that have been placed for over 10 years, particularly intraspine. At our hospital, at the medical center, we used the intraspine device a long time ago, and I have had to remove about 4 or 5 of these devices. In all cases where they had been implanted for over 6 or 7 years, yes, we have seen erosion. But we have also seen that there is a tissue around the spacer, and this makes it relatively easy to remove, and somehow it buffers the erosion between the spinous process and the lamina. And there isn't much fibrous tissue in the adjacent area. Because, for instance, in a revision surgery, might think it's going to be complicated, but no, in reality, no, it hasn't been complicated. This is a device that gives us time. It preserves our patient's range of motion, and it's not a definitive solution, as some of the previous presenters mentioned. It is something that could be decompressed, but I believe that something that we can point out is that all of these other options, they can continue to be viable options once the device fails. So you can still perform an instrumentation, you can have a till lift, you can perform an A lift. If the facets are okay and you have a reherniation, you can go for a lumbar disc prosthesis. So I believe that this device enables you to perform additional procedures in the future in case of a herniation. Additional comments? Thank you so much. Thank you for your attention, and you can contact me here in Guadalajara. I thank you for your participation. And before they leave the room, I would like to yield the floor to Dr. Aurelio for the closure of this event and provide additional information with respect to academic credit in your certificate of attendance. Well, first, in-house announcements. And the road before last, at that side of the group, there were these lenses that were just left there. I don't know if you know of anyone who misplaced or lost glasses. I am going to leave these glasses where the navigating device is located, and if not, we will leave these glasses with Andreas. So if anyone left glasses behind, and I hope that this belongs to a Mexican because the glasses were left right next to a 2 pesos coin. So I don't want to close this event, but without thanking you first for your time, for your patience, for your interest, for your questions, for your comments, for your criticisms, for all of the feedback that we have had from you. And I was thrilled by looking at the level of participation and your interests, and particularly having people come to this event from different places, from different parts of the world. So yes, we wanted to talk about different parts of the spine, cervical, thoracic, lumbar. What we wanted, because today was just an example of our approach. We saw, for instance, today how we can approach the same pathology from different perspectives with different levels of expertise. And I believe that the exchange of information that we have had today is what actually enriches this type of meetings. And yes, now the person that is going to proceed to the formal closure of the event has just arrived. Good afternoon, everyone. Yes, I was asked to close this event. Thank you. I want to thank each and every one of you for joining us, particularly our foreign speakers and all of the providers of equipment that support us. I want to thank the faculty and everyone that helped us, particularly Dr. Aurelio, Dr. Daniel Rios, Dr. Dietmar, all who helped us organize this program and to make it possible. I thank you. I hope that you have enjoyed the time we spent together, and I know that we will reconvene within 2 years. So thank you all. Les agradeceremos regresar el equipo de interpretación a su salida. Thank you for your devices on the way out.